Good afternoon. Good afternoon. Can I invite my colleagues, Dr. Sayyid Afifi, Dr. Tommaso Donati, and Ahmed Said, my moderators, Dr. Mohammed Hosni and Ahmed al-Mahrouqi, to join us on the stage. My name is Assam Osman. It's our job this afternoon to wake you all up after your gentleman's lunch. I warn you, if I see any of you snoozing, I shall find a difficult question to ask you. Our first speaker today is Dr. Ahmed Jamal. Okay. Okay, sorry, I'll start again. Our first talk is on the Shaggy Aorta by my good friend Dr. Sherif Kardawi. Sherif requires no introduction to all of you here. He's a very eminent figure in the region and in Egypt. And he's going to enlighten us over 8 minutes, Sherif, on the Shaggy Aorta. Thank you very much.
Okay, can we start? Good evening, everyone, and thanks, Dr. Nasser, for this elegant meeting, and thanks for inviting the IMAC group for this meeting. Actually, I know that there's intervention techniques now have been approached us according to the technical updates that we have with the advanced CTs, and new pathologies have been introduced to the field of vascular surgery. So I will discuss with you today one of the partially new diseases that led to us from this advancement in the CT, which is the Shaggy aorta. As far as we know, the Shaggy aorta depicts the severe aortic surface degeneration, extremely friable surface, and likely to cause spontaneous peripheral and visceral embolization or during minimal invasive procedures. That we can call the hostile aorta. It's a hostile aorta, it's not a benign. It is totally hostile aorta, we have to take care of this. So what we know about this Shaggy aortic syndrome? As far as we know, the Shaggy aorta has been identified as an independent risk factor for spinal cord injury, mesenteric embolization, cerebral infarctions after endovascular repair or many other minimal invasive repairs like TAVI and other things. The impact of Shaggy aorta have been studied in patients undergoing open and endovascular surgery, and in this publication they concluded it's a prominent risk factor associated with a very poor long-term survival rate. In spite of adaptation of certain Shaggy protocols to deal with this in the surgical field, the results have not getting any better with these protocols. Until we had the novel Shaggy aortic scoring system from Tokyo in Japan to predict the embolic complication following thoracic endovascular aneurysm repair. In this study, they just divided the aorta into 3 parts and examined every part ahead. And by a computerized CT scan, 3D dimensional study, they had a Shaggy score 1 point for each ulcer like thrombus, maximum thrombus thickness more than or equal to 5 millimeter, or mural thrombus occupying more than 2/3 of the circumference of the aortic diameter. And they concluded that the Shaggy scoring system is a very useful method to predict post-operative embolic complications. So how the Shaggy aorta might influence your decision-making in aortic intervention? Actually, it will definitely influence in each step. So starting from the indication, from head to toe, any atheroembolic event, Shaggy aorta should be suspected. And you can find this very widely out the range of our vascular scoping. That's the patient might embolize to the brain, might embolize to the lungs, might embolize to the visceral vessels, might embolize to the mesenteric vessels. And in the vascular domain, you will only see this embolization if it has the Bluetooth syndrome that will come to your domain. What about the intervention type? We had 3 types for intervention for dealing with this kind of aortic disease. We have an open and an endo and hybrid technique. But what data we have from literature about this till now? What about open surgery? We thought that open surgery is doing good in Shaggy aorta, but there is a comparative study between thoracoabdominal aortic aneurysm open repair with patient with and without Shaggy aorta. They concluded that the presence of Shaggy aorta is a risk factor itself. So Shaggy aorta with surgery is not going good. So we expected that the hybrid techniques might be more beneficial for patients for having Shaggy aorta. But this study for hybrid repair showed that the repair may proceed better early with surgery and late outcome with surgery than the hybrid techniques. So the hybrid techniques are inferior to the surgery. So what's remaining is the endovascular technique. And this paper saw that the thoracic endovascular aortic repair with Shaggy aorta, in spite of the presence of risk of atherioembolic manifestation, TCAR proved to be an effective and durable treatment in high-risk cohort. So what about the intervention technique? If we are going to intervene with an endovascular technique, you have to choose the technique of intervention, either open exposure or total percutaneous approach for treatment of this kind of disease. Open exposure is better than total endovascular percutaneous approach because open give you the window to deal with any distal embolization that can happen more safely and more accurately. What about the covered area? The presence of Shaggy aorta with any aortic pathology definitely will lead to increase the area should be covered, and this would be we must scan well from the CT and to decide the proximal and the distal landing zone, which must be relatively healthy in these segments. What about the protection protocols? In this kind of disease, you have to use whatever available in the protection protocols, starting from the brain protection devices, distal protection devices. All these devices be available at your site. Even the minimal invasive techniques regarding injection versus IVUS in Shaggy aorta, IVUS is much preferable. And minimal touching technique with your catheters and your wires should be available with you in dealing with such cases. What about the post-operative mitigation? Unlikely to the most of the patients with TCAR and EVAR, only when studies showed that statins may reduce this effect of the Shaggy aorta. And so we have to add statins in our scope of practice in our medication post-EVAR and TVAR, and that's not a routine in every case we do without Shaggy aorta. So do we have any other medication to be added? Some recommended to have an anticoagulation and double antiplatelet with this might protect patients from embolization. If you don't decide to intervene with this patient, how to follow up this patient? This patient must be closely followed up before it's too late to have an embolic manifestation and getting your patient at risk. Finally, I will show one of our cases with the Shaggy aorta. He's 70 years old male, hypertensive ischemic heart. He had a repeated embolic event. He had an abdominal pain, and he went to the GIT specialist, and he passed with some medication. Then he had an increase in his renal function and went to the nephrologist and passed with some medication. And then he came to our friends with the neurointervention. He had a stroke, and they called us to investigate this patient. After taking his history, we asked for a CT. We find an incomplete aorta with the Shaggy presence, as you can see here. So we decided to cover all. So we decided to cover the part, and the question here was all what to do, to cover the thoracic part or to cover the abdominal part, or how to deal with both, or simultaneously in 2 sessions. And as we can see here in the IVUS, in the intraoperative, we have a completely ununiform aortic wall all through the aorta. So we decided here to go all through to cover what we can cover. As you can see here in this CT, at the beginning of introduction, we have a dissection in the left subclavian, and this dissection was caused that the vertebral was a domain artery here, and this is the cause of the stroke for this patient. So we decided to have a TCAR for this patient, and then we had a subclavian stent for this patient at the same session, and then at the same session we went to have a CRAP technique to cover the infrarenal aorta. And this patient with a complete cover. So the take-home message, Shaggy aorta is not a benign condition. Shaggy aorta may influence your procedure outcome gravely. Embolization is the main concern when you're dealing with Shaggy aorta. IVUS is a very useful tool for accurate visualization. Avoid right arm access with Shaggy aorta. Avoid total percutaneous procedure with Shaggy aorta, and paving the way before TAVI procedure is a must with suspected Shaggy aorta. Thank you.
Okay, I would like to introduce Professor Mohammed Hosni, talking about endovascular management of rupture infrarenal AAA.
Dr. Nasser, are we 2 speakers short this session? Yes. So we can be lenient with time for our speakers. So we have some more time. So you have a few more minutes.
Thank you, Professor Nasser and the organizing committee for the kind invitation. There are 3 trials, the IAX trial from Netherlands, the ECAR from France, and the IMPROVE from UK. The IAX and ECAR, they have randomization of the patient after CT, while in the IMPROVE trial, they have randomization of the patient before CT. After that, they had the conclusion that there is no early survival benefit for EVAR following rupture AAA. There is a very weak indication in favor of EVAR at 90 days for patients eligible for both lines of treatment, and women may benefit more from endovascular repair. Time to discharge was shorter for EVAR. There is no evidence of high mortality among patients treated outside the routine working hours, and there is a strong relationship between short aneurysmal neck and the high mortality rate after open repair. And so in 2014, in the Vascular News, this was the title: there is no difference between endo and open repair for rupture aneurysm. But the conclusion of these 3 randomized trials may be unjustified and misleading. First, IAX and ECAR, they randomized very few number of patients, and they excluded high-risk patients in their trial, which might benefit more from endovascular repair. While these are the results of that IMPROVE trial depend on, and according to it, there is no significant difference between in the mortality between endovascular repair and open repair. But if we just stratify these results and the numbers, we'll find that the highly significant value in favor of EVAR than in open repair. And so the real conclusion should be that for rupture AAA, when EVAR is anatomically suitable, 30-day survival is superior in the EVAR group than open repair. This is a paper showing 14-year experience from 2 centers, showing that the EVAR-only approach has allowed EVAR treatment of nearly all incoming rupture AAA with low mortality and turnover rates. Without rapid surgical intervention, the mortality rate within 3 days approaches 100%, and if there is rapid intervention, this mortality can be lowered to 25%, provided that they are avoiding hypotension that leads to multi-organ failure. Our juniors should suggest or suspect the presence of rupture AAA in patients known to have a AAA and presented with abdominal and back pain, hypotension, collapse, pulsatile abdominal mass, pain radiating to the legs. And in this case, you should ask for a senior vascular surgeon within 30 minutes. It's important to maintain the systolic blood pressure between 70 and 90 millimeter mercury with a cautious crystalloid and maybe blood products. If the patient hasn't had a definitive diagnosis and the blood pressure is maintained above 70 millimeter mercury, CT angiography is indicated, while if the patient is unstable, rapid ultrasound will be the tool to be chosen. When you are looking to the CT scan, look to the neck, hostile proximal neck, it is the that could have different challenges, but iliac anatomy is really a contraindication for endovascular repair. We should have an anesthetist who is available 24/7, and I think this is the time to ask for a specialized anesthetist for vascular surgery. Be prepared with femoral and axillary access. There should be a way of transfer and centralization. There should be a trained clinician. The case should be discussed on a multidisciplinary team, and you had on shelf a stock like an aortic balloons and aortic grafts and chimneys. The staff should be capable of performing both the open and endovascular repair, and the use of aortic occlusion is very important, especially in open surgery if the patient is hemodynamically unstable. In this paper that had been said in the vascular annual meeting and analysis of the Medicare database, that showed that with low experienced surgeon, the mortality rate reaches up 50%, while it's half in high experienced surgeons. And interventionists and surgeons who perform EVAR in more than 1 hour will have a marginal success with implementation of a rupture EVAR program. The decision to put an aortic occlusion balloon catheter is dependent upon the severity of shock and the presence and the extent of the retroperitoneal hematoma. It can be placed under local anesthesia and be ready if the patient is hypotensive. This is the cat that should include long sheaths to support the balloon, a compliant balloon, stiff wire, long stiff wire, and 50 centimeter syringe with a contrast line mixed 1:1. It can be applied through a brachial access, through a brachial artery exposure, but the complications include balloon rupture and arterial embolism, but it's more stable if there's no long sheath. In these cases, if you are going to perform the EVAR or using the brachial access, the balloon will be slightly deflated to allow angiographic imaging of the selected infrarenal landing zones, and carbon dioxide is very useful in these cases. Femoral access allows a bigger sheath. It can be accessed more easily with lower risk of cerebral embolization. We need a long sheath in order to support the compliant balloon, which should be fixed outside the patient, and the balloon is inflated proximal to the rupture AAA, either supra or pararenal. The sheath should be protruded above the standard graft in order to allow the balloon withdrawal, and a second balloon is inflated after the main body has been deployed. In these cases, we shouldn't use a standard graft without suprarenal fixation. In presence of hostile neck, it's very important to take more time in planning and choose device from which available on your shelf, and you are allowed to use combine grafts from different companies, and it's preferable to use the graft that you are familiar with, even if it's not the optimal solution. Anesthesia can be local or general. Local is, especially in unstable patient, is very helpful, provided the patient is cooperative and is able to hold his breath while taking the angio. Percutaneous closure devices should be kept for patients who are stable, and heparin, if the patient is unstable, should be postponed, and if the patient is stable, we'll give only at the beginning of the procedure 3,000 to 5,000 international units. You can go for aortic iliac if you find difficulties in cannulating the contralateral limb with plugs and femur-femur bypass. You can sacrifice one of the renal arteries and don't even look to the accessory renal arteries. Chimney techniques, you can use it using either a balloon expandable or self-expandable stents. Each one has its pros and cons. The balloon expandable stents, the privilege that the balloon is there, and so if it's required to the balloon, the aortic graft, you can easily inflate it, the covered stent, in order to prevent its collapse. In these cases, please choose the graft size with minor or no oversizing at all. These are examples of the cases. In rupture AAA, طبعا endoleak shouldn't be accepted at all. You should fix it by whatever mean you can. The main complication is the abdominal compartment syndrome, which leads to multi-system organ if it's about 30 millimeter mercury, and it's due to combination of retroperitoneal hematoma and bowel edema. The incidence of mortality in open repair is 50%, while in endovascular repair is only 20%. I think that in Egypt, up till now, with the current facilities, not all cases of rupture AAA can be managed in endovascular technique. For our juniors, once you exclude heart, please think about the aorta. Thank you.
Thank you, Professor Dr. Mohammed Hosni, for this very nice presentation. Next speaker, Professor Dr. Khalid Chawi. He's talk about aortic intervention in vasculitic patient.
Thank you, Mr. Chairman, and many thanks for Dr. Nasr Saeed and the organizing committee for kind invitation. Aortic intervention in vasculitic patient. I don't have any conflict of interest. Aortitis or large vessel vasculitis is a chronic inflammation affecting the aorta and its major branches. This chronic inflammation leading to diffuse wall thickening, loss of elasticity, stenosis, occlusion, dissection, calcification or aneurysm formation. The causes of aortitis, infectious causes as TB and syphilis, and non-infectious causes, the commonest is TCAR, giant cell aortitis, Passage syndrome, and the chronic idiopathic periaortitis, and the other causes like polyarteritis nodosa and systemic lupus and immunoglobulin 4 aortitis. The clinical presentations of aortitis varies from asymptomatic, vague constitutional symptoms, hypertension, spontaneous dissection, or aneurysm rupture. According to American College of Rheumatology, there is 6 diagnostic criteria to diagnose TCAR, age of symptoms below 40 years, extremity claudication, especially the upper limb, decreased brachial artery pressure on one or the both sides, blood pressure difference more than 10 millimeter mercury, audible per way over one or both subclavian or abdominal aorta, and geographic findings, narrowing or occlusion of the aorta or primary branches, not caused by atherosclerosis or fibromuscular dysplasia. TCAR usually is a progressive disease with relapse and remissions. The case is a male patient, 37 years old, hypertensive, not diabetic, with long-standing history of vasculitis, affecting the large vessels, affecting the aortic valve. Patient complained from severe aortic valve regurg and affecting the renal vessels, and there is history of left renal stenting. The patient is a chronic renal failure on regular dialysis and complained from intermittent loin pain. On presentation, the CRB is 22, it's high, erythrocyte segmentation rate also is high, 45. Echo shows mild mitral regurg, moderate to severe aortic regurg, and mild tricuspid regurg, and diagnosed as TCAR. Patient is a candidate for for cardiac intervention to replace the aortic valve and repair the ascending aorta, and also candidate for renal transplantation. For these procedures, the patient do CT angiography as a preoperative preparation for this intervention, and accidentally discovered that the patient complained the CT shows right aortic lateral aspect aneurysm at the level of the renal artery, 28 by 25 millimeter with narrow neck, 3 millimeter, and occluded left renal artery stent. The problem here that this sacral aneurysm is actually, we don't know 100% the origin of the aneurysm. It is from the right renal artery or from the abdominal aorta. The plan for management of this patient, the first is important is activity control of the TCAR by intravenous steroids before the intervention, medical therapy for hypertension and left ventricular dysfunction. And we have two options to treat this patient: surgery intervention or endovascular intervention. Surgery option is very high risk due to the cardiac problem of the patient, and the endovascular have little bit risk than the surgery, and we go to the endovascular approach. From the femoral axis, we do the primary angiogram using the big tail and raise the aneurysm at the lateral aspect of the right side of the aorta. And using Bern catheter, we selectively cannulate the aneurysm in the video on the right side. Then we deploy aortic stent, 32 by 49 millimeter. It is aortic cuff from Medtronic to deploy in this region at the level of the SMA, and choose the stent. It's very difficult in this patient as in showing the angio, the diameter of the abdominal aorta at the level of SMA, and for above its diameter 29, and decrease in the diameter gradually to become 21 below the level of the renal. So the suitable aortic stent we found to be used this cuff stent. Then coiling of the aneurysm through the Bern catheter, which live in the aneurysm before the deployment of the stent. We use a coil, interlock coil, 15 millimeter by 25 centimeter in length, and we do the final angiography from AP position on the left side and the lateral position on the right side to show patency of the SMA and good position of the graft. Take-home message that the most common cause of aortitis is TCAR arthritis in young patient and giant cell aortitis in the older patient. There is at least 3 diagnostic criteria to diagnose the TCAR arthritis. This digital subtraction angiography and CT angiography and MRA. It's a gold standard for diagnosis of vasculitis. Disease activity control with the steroid and immunosuppressive agents is the cornerstone of therapy for non-infectious aortitis. Treatment of hypertension and congestive heart failure is still standard guidelines, and intervention varies from ballooning, stenting, or surgery with high risk of recurrence in these interventions. And every effort to control the disease activity before the intervention, follow-up for disease in other regions of the aorta must be done. Thank you for your attention.
Right, so that brings us to the end of our presentations. That means we have some time for questions. So we're supposed to finish at 3:45. Now is what time is it now? It's so we have 10 minutes. It's a good thing we didn't have all the speakers. Right, I open up the floor to questions, comments, anything to Dr. Nasser has a...
Dr. Sherif, thank you for your nice presentation. It's actually very important and is something adding great beneficial for our knowledge. I just wonder about the protective measures against the stroke in a Shaggy aorta in comparison to atherosclerotic aorta. What you should do more in Shaggy aorta.
Yes.
From my point of view, I consider all aortic, atherosclerotic aorta as a Shaggy aorta. What?
Yeah. The atherosclerotic aorta is a part of Shaggy aorta, but it's not that extensive part as the Shaggy aortic term. When we deal with this kind of lesions, we have to have a certain strategy. First, not to have any aggressive maneuvering during manipulation.
You should do this in all cases. For example, if you are going to do TVAR or EVAR, I think this is instruction for Shaggy aorta or non-Shaggy aorta.
But we have to be more cautious with the Shaggy aorta. Regarding the injection, when you inject contrast with pressure. Using IVUS in Shaggy aorta is much more beneficial than using this pressure just to let any emboli goes in the peripheral circulation. Having brain protection devices like filters, if you are going through the left subclavian or even the right subclavian, or even the left subclavian, you can use these filters to protect the patient during your procedure. So the manipulation itself have to be customized according to the patient and according to the IVUS finding when you go for previous diagnosis intraoperative with the IVUS. You can see clearly where is the area, the most threatening area that it might be causing the problem, and you can mark these areas and dealing with this very cautiously.
So if you are going to do EVAR for a patient with a Shaggy aorta, you consider don't proceed to introduce the wire to the arch of the aorta. You have to stay below the subclavian is much better if you can, or you can do it as we used to do.
No, but you have to take your wire very safely. You have to take your stiff wire through the catheter and just put it there safely.
Just delicate.
Yes, you have to have your support maintained, but you have to take this support safely without any aggressive maneuvering.
Okay.
Sherif, I think I want to add a comment, Dr. Nasser. In these cases, as Sherif said, exposure of the common femoral artery is very important, and clamping the superficial and profound femoral artery during the whole procedure in order to prevent distal embolization. These are very important. Never go.
Thank you, Dr. Mohammed, for your nice presentation. Actually, my question regarding post-endovascular repair of ruptured AAA abdominal compartment syndrome. Tell me your experience about dealing with that issue.
Alhamdulillah, up till now, I didn't make a case with increased intra-abdominal pressure to the extent that I need to intervene. But I think some of my colleagues routinely go for evacuation of the hematoma immediately post-implantation. I have never done that. I waited and observed the patient, and if anything happened, I can go and do the. I haven't seen it. I don't know.
Actually, I had this experience with two patients. First patient, I left him. Even with the ecchymosis in the flanks, it was very clear. I did nothing for him. The second one, and he passed very well. The second one, my colleagues of intervention radiology just pushed me to have a pigtail for evacuation, not a surgical evacuation, a pigtail for evacuation. The pigtail drained nearly 300 millimeters, nothing. So either to leave this patient till it goes, mostly it went smoothly, or to go for open evacuation if it's my. Pigtail, it's useless. It's useless.
The problem with abdominal compartment syndrome is it has to be done prophylactic. If you do it, if you wait until the patient presents with it, the horses are out of the barn, as they say. So you're lagging behind, and you can't catch up. So those patients will need decompression prior to them presenting with a full compartment syndrome. And there are some criteria we use in our center that we treat those patients with prophylactic abdominal decompression. If someone needs more than 4 units of packed RBC, someone who's hemodynamically unstable throughout the procedure, someone who had the balloon up in the thoracic aorta more than 10-15 minutes, those are the ones who will need prophylactic compartment syndrome, because once they develop it and we do decompression afterwards, we're already lagging behind.
More bad picture than this, and they pass smoothly without need of, if there is any trial, any scoring, you have it?
No, we don't have a scoring system, but we have got burnt with several patients who really, we waited, we did the EVAR, they went to the ICU, they started to have compartment syndrome, we took them back, and they never recovered. They become hypothermic, they become totally, with a lot of coagulopathy, and you can't catch up.
Yeah, I think that's the waiting. I'm trying to keep my equipoise, but as an open surgeon, I don't know what you mean by abdominal compartment syndrome. I've not seen it in 25 years of open ruptured aneurysm repair. I have a question, just to be the devil's advocate in the audience. How many surgeons in here can tell me that they have a record of the aortic aneurysm surgeries they've done over the last 5 years that the patient and the public can access? All of them, ruptured, non-ruptured. How many here can say that they have a patient level with taxes? Yes, it probably does. But the point I'm trying to make is we are extrapolating data from trials done in the West, and I randomize to improve. And I'm not sure that I agree with Dr. Mohammed's interpretation of improve, but I'm trying to apply them here. There are two things that will predict the outcome of ruptured aneurysm mortality. And I published a paper in Vascular Surgery in 2006 looking at this. One is how long it takes you to get in there to repair it. So if you do it within the first hour or from 1 to 4 hours. The second is the complexity he's talking about, the neck. So we looked at operative time as a surrogate marker. So if you are outside the 1 hour from arrival and you have a long operation, you have a statistically higher risk of dying. More so than if it was a general surgeon doing your operation or a vascular surgeon doing your operation. This is back in the day. So I think that just to say because mortality is 50% somewhere else and it's 25%, it doesn't mean these are your results. If I ask all the surgeons in Egypt to tell me what their ruptured aneurysm mortality rate is with patient level data, would anybody be able to answer that?
We should have registry for this to give you the right answer.
Exactly. So we don't have a registry. And it's not just Egypt. The whole of the Middle East, we don't have a registry. In the UK, I can tell you what my results were from 2007, when they started to collect them, until I left. That is available to the public. So then you can make informed decisions. I do a ruptured open aneurysm well, yeah? And my data shows it. So why are you pushing me down the EVAR route? Mohammed might be doing it down the EVAR route very well as well. Why should we push him down the open route? And I think we've got to, there are horses for courses. And my suggestion is, I keep saying this every meeting, until we have vascular registries, we are a group of friends getting together, talking in a room, and nothing more.
Definitely, a registry is very important. I think in one of the meetings in the IMAX, I asked for that. But nowadays, we had been obliged by the Ministry of Health. No one will be able to do an EVAR or TVAR without registering the patient pre, the angio, during the procedure, and the strict follow-up that will be published soon. Otherwise, this center will not be allowed to do an endovascular repair for abdominal or thoracic aneurysm this year, starting from this year.
Dr. Muhammad, can I just explain something? Let us speak practically. I will tell you a scenario, and you can give us what you are going to do in this situation honestly. And I am dead sure you are very honest. If you are in a hospital, while you are in the hospital, a patient coming with rupture, AAA, and his blood pressure is steady around 80, 90. So, and as you know well, we don't have the stuff on shelf. So you will think to wait until things coming. It may take 1 hour, 2 hours, 3 hours, or you can proceed for open. So, and please don't forget the pressure from the patients and the patient's relative. So what's the right way to solve this problem?
Definitely, if there will be a delay, I'll go for open surgery. I will go for open surgery if there will be a delay. If there will be a delay, but if the patient can wait for a while, for an hour until the CT had been done.
Yes, this is exactly what I want to say. As long as we don't have the stuff on shelf around, and we know very well that if you're asking to bring the devices, may take a couple of hours, 3 hours, 4 hours. It depends on the time you are in night, you know. So sometimes you cut the long story short and try to give a chance for the patients. If you are dead sure, the delay will affect the result.
But nowadays, I think we have done a lot of cases, even outside Cairo, with ruptured thoracic and abdominal aneurysms, and we have been able to go and do the procedures in less than 3 hours.
Yeah. One day we've been lucky because one patient has a traumatic descending thoracic tear, root traffic accident, and fortunately enough transferred from Aswan to our center by aircraft. But fortunately enough, the doctor over there told us the story completely, and the patient coming within 1 hour in our center. We've been ready for everything, and we did TVAR for him on emergency basis, and the result was good. You know, because the patient, while the patient in the air coming to us, we've seen his CT, we've taken a measure, be ready. But this situation is not everyday business.
We have one final question from Dr. Khalid.
It's not a question, but it's a comment on Dr. Nasser. Even I am saying about the AAA, rupture the AAA. Even if we decide to do a surgery for the patient, it will be not less than 2 hours to prepare the patient and to prepare the blood and the anesthesia. And I think this time, that is, we can... If the patient has a leaking, not ruptured aortic aneurysm, he can withstand 3 or 4 hours. But if it is intraperitoneal rupture, he will die within minutes. If he can,
really, we are not talking about rupture, because rupture usually will pass away before.
If he can withstand, I think EVAR is better than open surgery.
معلش يا خالد, for me, there is non-ruptured and ruptured. Yes. Leaking, contained, whatever it is, these are subjective terms that surgeons come up with, okay? You have Those who rupture into the peritoneal cavity, they don't make it to your hospital anyway. They die on the way there. Yes. Yeah. You have those who rupture retroperitoneally, and it's contained. It can be a little rupture retroperitoneal, or it can be a big rupture retroperitoneal.
I'm talking about the contained rupture.
Sure. Yes. My suggestion is, if it takes, and thank you for your honesty, if it takes 2 hours to get a ruptured aneurysm on the table in the institute, then the institute needs some simulation moulage training. So that, and this is the point, it's not just about you. This is what we found. The surgeon is the smallest part in this. It's about anesthesia, ICU, et cetera, et cetera. Yes. And if you get them from the emergency department to the OR within 60 minutes, they do well. They do better than if you leave them 3, 4, 5 hours. My last point is, if you don't have consignment EVAR stents on the shelf, I suggest you should not be doing REVAR. You're better off putting that patient in an ambulance and sending him down the road to a unit that does. Because if they have consignment stents on the shelf, that means they're a high volume unit.
We don't have on the shelf, but I think we can bring the EVAR within 1 or 2 hours.
I think, Dr. Assam, you remember the Leicester study. If the patient was leaking or whatever, rupture, arrived to the hospital alive and with steady blood pressure, whatever it is, he has a couple of hours. You have to operate before, because the majority of this coming if the delay before after 2 hours. So if you don't have a center with high volume fixing aneurysm, I think the result would not be good.
Dr. Assam, you have told now that you haven't seen a case of increasing intra-abdominal pressure or compartmental syndrome in your cases, in open cases. I haven't seen it, luckily I haven't seen it also, neither in my open cases, nor in endovascular cases. But what do you say about the results of the papers? This is only one paper that have shown that the incidence of mortality from compartment syndrome is nearly the double in open repair than in endovascular repair.
Open repair?
Yes.
I'm not sure which paper you refer to, but I think what you're saying is there is a constellation of signs and symptoms of an increased intra-abdominal pressure with oliguria and the patient being acidotic. You call that a compartment syndrome. I call it just the irreversible effects of the three triangle of doom, which is coagulopathy, acidosis, hypothermia. That's what kills these patients, and they can die with a compartment syndrome that's a compartment pressure that's high or a compartment pressure that's low. But I'm going to end the session because we've gone over time. 2 more minutes? Oh, I've been given 2 more minutes for my colleague here to respond.
So, even with open repair, do you close all of your patients after open repair for ruptured AAA? After open repair, do you close all your patients?
Almost always. I have left over 2 open repair to close.
Why?
Because I felt that to close these patients was going to affect their...
That's exactly what compartment syndrome is.
Yes, but to repair an open repair and then get that constellation of symptoms and then come back to open the abdomen again with open repair, certainly, and I've done 45 ruptures in 10 years. I mean, we used to do about 5 a year. I used to do 5 a year. I've not had to do it. But I can understand with the REVAR that it continues to be a problem, especially if you have a type 2 endo leak, which you often have, into the sac and into the retroperitoneal. Anyway, are there any further questions, or should we wrap the session up? We have a question here, one last question.
Just for Dr. Khalid. I don't know if he's here. Dr. Khalid Chawi. Oh, Dr. Khalid. I just was surprised. I mean, you put a 32 cough, aortic cough, Medtronic cough. But this means actually that you are putting 30, it's a funnel-shaped neck. It's actually 29 proximally and 21 distally. And I don't think that actually this is the best option to put...
Stent distally not deployed in the 21.
You mentioned that actually the distal
I mentioned that there is gradual decrease in the diameter of the abdominal aorta from the 29 and 21 more distal, but we put the stent in the diameter 25. Only 5 centimeter of the abdominal aorta covered by the stent. The proximal is 29 and the distal 25.
Okay, I mean, I still feel that 25, if you put 32, it's a bit too much. It might have puckering of the stent, and this might occlude later on.
It's the available stent, no another stent can be in this situation.
هتبدأ الأول يا باشا؟ نديلهم ده بقى. مش شغال. Good afternoon, ladies and gentlemen. We're gonna start session 13 this afternoon, and I commend you for staying that late with us after lunch. Our first presentation is gonna be by me, so please bear with me. And I have a disclaimer, my presentation is 10 minutes, so I will need 2 more minutes. Dr. Nasser told me the presentations are 10 minutes, not 8. It's okay. The next. First, I would like to thank the organizing committee and Dr. Nasser for the kind invitation and allowing me to present on this subject. TCAR, the current status, how did we get here and where we're going? I have no disclosures. So stroke is very common in the United States, about 800,000 cases per year, and about 15 to 20% of those are related to the carotid artery disease. Based on the NACET and the ACAS trials, we base our management of carotid disease. All of the patients will receive medical therapy with interventions reserved for symptomatic patients with greater than 50% stenosis and asymptomatic patients with greater than 80%, that is severe stenosis. Carotid endarterectomy until today remains the gold standard for care for those patients. According to the AHA Scientific Council guidelines back in 1998, they stated that carotid endarterectomy should not be performed except for patients with less than 3% of mortality and stroke in asymptomatic patients and less than 6% in symptomatic patients. Carotid angioplasty started in multiple stages. The first by DeBakey in 1967, which he did gradual dilation for FMD. But the first series were published by Dr. Dietrich back in the mid-90s, and that had 11% of stroke, which is much higher than the benchmark stated by the AHA Council. With improved technique over the following years, global experience of cervical carotid artery stent placement back in 2000 showed of over 5,000 cases that the procedure-related death and stroke is about 5%, which approached the benchmark needed by the AHA. Multiple trials afterwards for carotid stenting have evolved, but the landmark trial was the Sapphire trial that compared carotid endarterectomy to carotid stenting, and the conclusion was that carotid stenting is not inferior to carotid endarterectomy from the major adverse events, and that carotid stenting significantly reduced cranial nerve injury, and it also showed that carotid stenting is actually a durable procedure. That led to the FDA approval of carotid stenting back in 2004. And fast forward, we got another landmark trial, which is the CREST trial, that showed that the carotid stenting is a less invasive alternative to carotid endarterectomy that is patient-friendly, durable, but with excessive procedural stroke risk. Why is that? That's because, number one, you go through the aortic arch and manipulate the lesions in the arch, manipulate the lesion of the carotid before putting the embolic protection device, and even after putting the embolic protection device, it can malfunction during the case or collect thrombus. For that reason, the current status is that carotid endarterectomy is the gold standard, where over 80% of carotid interventions are done by endarterectomy and only about 17% by carotid stenting. And that is contrary to most of the other vascular beds in the body, which most of the time they are done by endovascular. So carotid endarterectomy has a low risk of stroke, but at the expense of increased MI and cranial nerve injury compared to carotid stenting. On the other hand, carotid stenting carries double the risk of stroke compared to carotid endarterectomy. But looking further into that, we found that carotid stenting carries the risk of stroke during day one. That's during the day of placement of the stent. But after that, the risk of stroke approaches the same risk as carotid endarterectomy. So according to the CREST trial of 10-year data, there is no difference in post-procedure ipsilateral stroke or restenosis in stenting or carotid endarterectomy once the first day of the procedure has passed. So the problem is delivery. It's not a problem of performance. If the stent is delivered safely, long-term outcomes are the same as carotid endarterectomy. So that led to the presence of the current technique, which is TCAR. And TCAR is essentially making a small incision in the lower part of the neck, just above the clavicle, accessing the common carotid artery using a sheath, and another sheath put in the femoral vein, connecting them with a tube, and over that tube there is a filter, and allowing by the pressure difference flow to come from the carotid into the femoral vein, and at the same time we start clamping the proximal common carotid artery, and that will allow for reversal flow from the internal and the external carotid back down into the femoral vein. That way there is nothing going up into the brain. That will allow you to go through the lesion, put your stent and balloon angioplasty without creating any further embolization into the brain. This is the incision. It's in between the two heads of the sternocleidomastoid, just above the lower part of the clavicle. So with that technique, they're establishing embolic protection before the lesion is crossed. There is flow reversal, which is essentially equivalent to surgical back bleeding, and avoiding the aortic arch. All of that will reduce the risk of stroke. The first in-man proof of concept trial, which is the PROF trial, showed that TCAR has MRI diffusion-weighted hits in the brain that are equivalent to carotid endarterectomy from previous studies, and that is much less than transfemoral carotid stenting. That led to clinical trials looking at TCAR, and that was the Roadster trial and the Roadster 2 trial, and they actually looked at patients who are high surgical risk for carotid endarterectomy. They're not standard risk, they're the hard surgical risk. And to the amazement, those patients have a very low stroke risk with TCAR. 1.4% with the Roadster trial, less than 1% with the Roadster 2 trials, which are much less, if not equivalent, to carotid endarterectomy, and much, much less than carotid stenting. Remind you, those patients in the Roadster and Roadster 2 were high-risk patients with a very low risk of stroke compared to the standard risk of stroke in CREST trial. It also showed that the TCAR had a powerful reduction in surgical morbidity. There is much less MI and much less cranial nerve affection, which is equivalent to carotid stenting. So it's the best of both worlds. It has less risk of stroke than carotid stenting and less risk of surgical problems than carotid endarterectomy. Not just that, it was found that TCAR is easy to teach and to learn. Half of the surgeons who performed TCAR in those trials were actually TCAR naive. They had less than 5 cases per surgeon. And that shows that the risk of stroke and MI and death was consistent no matter how that was the level of experience of those surgeons for TCAR, which is very different from carotid endarterectomy and carotid stenting. So all of that was done for carotid. Can you, please? All of that was done for carotid high-risk surgical patients. Now, that led to the FDA to approve TCAR for even standard risk patients. So who is a candidate for TCAR? There are some anatomic criteria that are needed to be able to perform a TCAR. You have to have a good length of the common carotid artery below the lesion to be able to put your device in the common carotid artery. The common carotid artery has to be free of disease, has to be at least 6 millimeter in diameter, and the internal carotid has to be at least 4 millimeter in diameter. This is present in about 70 to 85% of patients with carotid disease. Not a good candidate for TCAR are patients with heavy calcification that is essentially circumferential in the carotid artery, patients with short common carotid, diseased common carotid, or open laryngeal stoma, and patients with radiation dermatitis. So the procedure is safe and can be performed easily and easy to learn, but the biggest risk of stroke is not actually related to the procedure. It's related to medication management on blood pressure. So TCAR medication is the first reason why you can get a stroke after that procedure. You have to have double antiplatelet therapy started at least 3 days before the procedure, and the same with statins, and that should be continued for after the procedure. So without the proper medication, patient can get strokes. The other part is patients after TCAR, they tend to have hypotension, and that's the other biggest reason why you can get a stroke. So for those patients, you have to maintain the blood pressure above 90 at all cost. So with that, the conclusions are TCAR is a safe and effective intervention for the management of extracranial carotid disease. Current evidence suggests that it has the best of both worlds, equivalent to carotid endarterectomy for stroke risk, and equivalent to carotid stenting for surgical risk. Can you just a couple of more points? The procedure is easy to learn, and results are consistent irrespective of the experience level of the operator. Standardization of medication and management of blood pressure are the most important to avoid major adverse events. The procedure can be performed on over 70% of patients, and we still lack randomized controlled trials to compare it head-to-head to carotid endarterectomy. Thank you very much.
The second speaker will be Professor Samer Al-Koussayer. He will talk about update on the management of asymptomatic carotid stenosis, the recommendation from ESBS and SBS. Go this way up. This one. Yeah. Good afternoon. First, I'd like to thank Professor Nasser for inviting me for this nice meeting. I'm going to speak about a very debatable subject, which is a update on management of asymptomatic carotid artery stenosis, with the recommendation from the ESVS and SVS. Before we start, let's look at the natural history of asymptomatic carotid artery stenosis. Very nice paper from Japan. They found the incidence of carotid artery progression, asymptomatic carotid artery stenosis, is high, even the use of aspirin and statin. Another retrospective single-center study, they look at all patients came to the hospital with a carotid-related stroke, and they found 7%, they already have previously asymptomatic carotid artery stenosis more than 50%. Even though 50% they were on antiplatelets, 55 were on statin, and 35 we were on both. So what they conclude that asymptomatic patients on medical therapy have less severe carotid-related stroke, but still on high risk of having carotid-related stroke. So what they conclude that medical therapy is unlikely to be sufficient stroke prevention for patients with significant asymptomatic carotid artery stenosis. This is another paper published recently. They look at the relationship between asymptomatic carotid artery stenosis and cognitive dysfunction and fall, and they found that asymptomatic carotid artery stenosis associated with impaired mobility and cognition that are accompanied with increased fall risk. This impairment increased with the increase of the severity of ICA stenosis. So what the guidelines is saying about that? We have two major guidelines, one from the Europe, ESVS 2017, we have an update one, and we have from United States. Let's start with the European ESVS guideline, the new one. They still didn't change it from 2017. They're still saying if you have asymptomatic carotid artery stenosis, 60 to 99%, and you have life expectancy more than 5 years, favorable anatomy, and more than one feature suggesting high stroke risk on PMT, they still recommended to do surgery or stenting. What they mean by high risk, you mean if you have contractile TIA stroke, ipsilateral silent infarction on cerebral angiogram, in the ultrasound you see stenosis progression more than 20%, or spontaneous embolization on transcranial Doppler, impaired cerebral vascular reserve, large plaque, occluscent plaque, or hypoechoic area on ultrasound, or NMRA if you see intraplaque hemorrhage or lipid-rich necrotic core. So if you have any of these risk factor, then you have to do surgery. What about United States SVS? They depend, guidelines, they depend on two old trials really, but both trials, they already have an update. They depend on the ACAS trial from 1995, and we have an update 2024, and they depend also on ACAST, and then we have an ACAST 1. If you look at ACAS study in 1995, it's a prospective randomized trial. They have about 1,600 patients. They follow up patients for 5 years, and all patients, they were on aspirin. And they compare medical versus carotid endarterectomy, and they found no difference between two groups in the incidence of major stroke or death. But the incidence of any ipsilateral TIA or stroke or death was lower in the surgical group. So what they conclude that CA reduced the risk of any stroke or death from 11 to 5% in 5 years, with patient asymptomatic carotid artery stenosis more than 60%, with reduction about 53%. So the ACAS recommendation recommended CA for patient age less than 80, as long as the expected combined stroke and mortality rate is less than 3%. Then we have the European trial, or ACAS trial. Also it's a randomized control trial, about 3,000 patients, 5 years follow-up. And the trial also showed the advantage in limiting stroke and death at 5 years for CA compared with maximum medical therapy, 4.1 versus 10%. And they found this 5 years risk for all stroke in the CA group was reduced by half, and the same for fatal or disabling stroke in CA group comparing with the CA deferred group. Then we have an update on this trial where they follow up patients for 10 years, and now we call it an ACAS 1. And they found that the benefits continue even after 10 years with a reduction of stroke from 17.9 to 13.3 was gained about 4.6%, and half of this reduction was in disabling or fatal stroke. So what some people, they can argue about all this trial, there was no statin, and this is very common, discussion about these trials. But if you look at the ACUS-1, it showed that the stroke risk with the CA plus medical therapy was nearly half that of medical therapy alone, irrespective of whether patient receiving lower lipid-lowering drug or not. So statin helped to reduce the incidence of stroke, but still, if you add surgery to statin, you still have much benefit than if statin alone. And you can see that 1.3 versus 0.7% if patient was on a statin, and if patient not on statin, still increase the stroke from 3.3 to 1.8%. Then we have a paper published recently from Conrad, and he found that best medical therapy failed to prevent carotid artery progression in 40% of the patient and to prevent ipsilateral neurological symptom in 12%. Also, he argues that not all asymptomatic patients are the same because patient may get TIA while he is asleep and then he wake up without no symptoms. So we label this patient as asymptomatic even though they may be symptomatics. The second thing is that there is evidence that cognitive function improve after CA or CAS, where there is no improvement in medical treatment. All this led the Society of Vascular Surgery to give us a very strong recommendation. This is a new one with grade 1B. In low surgical patient, risk patient with asymptomatic carotid artery stenosis, more than 70%, we recommend CAA with best medical therapy over maximum medical therapy alone for long-term prevention of stroke and death. Very strong recommendations. But to get this result, patient has to have at least 2 years survival, 3 to 5 years, because you don't see its benefit until after 2 years, and your combined stroke and risk and death should be less than 3%. And they found no difference between male and female. So after all this data, if you're still not convinced that we have to do surgery for asymptomatic carotid stenosis, at least consider this kind of patient to do surgery for them. If they have initial degree of carotid stenosis, especially more than 80%, if you have a progression in the severity of asymptomatic, because it's increased or double the risk of stroke, especially if you see more than 20% progression of the stenosis. If you see asymptomatic embolism detected on transcranial Doppler ultrasound, ipsilateral silent embolic infarction on CTA or MRI, or you see some morphology on ultrasound, as we said, if you have like more than 3 ulcer, because this you increase your risk of stroke at 3 years, large plaque area, plaque echolicity, or intraplaque hemorrhage, or if your patient has a reduced cerebral blood flow reserve. So at least this kind of patient, we have to do surgery if we don't have to do all of them. What about stenting? I think the previous lecture talked about it. If you look at the ACUS-2, they look at the 30 days rate of death or any stroke was higher for CAS, but was not statistically significant. And 5 years rate for procedure death or any fatal or disabling stroke was similar. But if you look at 2017 meta-analysis of 5 trials, the ACUS-1, CREST, EVA, 3S, ICSS, and Sapphire, compare CA with the CAS, they found that peri-procedure stroke was higher for CAS comparing with the CA, but peri-procedure and ipsilateral stroke during long-term follow-up was the same, and the composite outcome of death, stroke, and MI was the same. This is a very nice retrospective randomized trial using the VQI database. They compare TCAR with the CAA and the transfemoral carotid artery stenting, and they found that the TCAR is very similar to the surgery, but regarding the stroke, but it decreased. Just 1 minute, I think, almost done. Thank you. So if you compare TCAR with the carotid endarterectomy, they was both the same, but TCAR was, of course, less chance of cranial nerve injury. But when you compare TCAR with the transfemoral stenting, there was 72% reduction in stroke and 65% reduction of stroke and death. What patient are likely to benefit from revascularization? Severe comorbidity, limited life expectancy, prior disabling ipsilateral stroke, or if he has an occluded ICA. So conclusion, patient with more than 70% asymptomatic carotid artery stenosis, he should be considered for CA, TCAR, or transfemoral CAS, but he has to have at least 3 to 5 years life expectancy, and your stroke rate and death should be less than 3%. Determine which technique based on the presence, absence, or high-risk criteria for CA, TCAR, or transfemoral CAS. Upcoming randomized hopefully will give us an answer to comparing best medical treatment regarding with stenting. And this is phase 2 and CREST 2. Thank you very much for your attention.
Thank you, Dr. Koussayer. Next presentation would be a recording recorded presentation by Dr. Ahmed Zakari, who's actually joining us with the Zoom. Can we get his presentation up, please? Dr. Zakari.
Okay.
Good afternoon. Thanks for the organizing committee for allowing me to present about carotid artery stenting. Carotid artery disease and stroke is far worse than death. These are the landmarks, in my opinion, for carotid artery management. The first carotid endarterectomy in 1954, the NASIT trial comparing carotid endarterectomy versus medical management, the ACAS trial comparing carotid endarterectomy versus medical management for asymptomatic disease. Then we move to carotid stenting at this stage, and this is SAPPHIRE trial, carotid in a high-risk patients, carotid artery stenting versus endarterectomy. No medical management here. The AV-A3S trial, carotid artery stenting versus endarterectomy in high-risk patients. So these are two high-risk trials. And then the CREST in the standard risk patients, carotid endarterectomy versus stenting, and then the Ruptured, which is the TCAR registry. This is the NASIT trial, and followed by the ACAS trial. And this shows the risk reduction of 16% in the NASIT for symptomatic, and for the asymptomatic, an absolute risk reduction of 6%. Then came the SAPPHIRE trial. The SAPPHIRE trial was the first between carotid endarterectomy and stenting. Randomized trial, not a huge number, 150 in each arm. And this is a high-risk patients with specific, very specific high-risk criteria, physiologic or anatomic. And the stroke rate was similar, but higher risk of MI in the carotid endarterectomy, of course, in the high-risk patients like this. Therefore, if you combine these, endpoints, then it's carotid artery stenting is non-inferior to endarterectomy. At 1 year, the same risks are maintained. Stroke rate is the same, higher MIs in the SAPPHIRE, in the carotid stenting, and the endarterectomy has a higher MI risk. This went into the Wall Street Journal before going into the New England Journal of Medicine, which is a landmark in the history of medicine. And therefore, everybody was jumping on carotid stenting at this point, and we thought carotid endarterectomy is going out with the door. The 3-year SAPPHIRE still maintained equivalent stroke rate with carotid stenting, and the re-intervention rates were not higher for the carotid stenting. At this point, things has changed after this, and we started to find out that it is not the future as we thought. The AVA3S trial is a severe symptomatic patients with significant stenosis and the multi-center, and it has to be stopped prematurely. It was done in France, and the carotid artery stenting is 9.6. Stroke was 30-day was 9.6 stroke rate and death. 9.6% in the carotid stenting and 3.9%, excuse me, and 30 in the carotid endarterectomy, 3.9%. And the study was stopped because of the worst outcome in the carotid artery stenting. Then came the CREST study, which is for standard risk patients with this embolic protection, industry-sponsored by Guidant. And it showed that the carotid endarterectomy is safer, and the stroke rate is double in the carotid artery stenting versus the endarterectomy. Watch here, the number of patients randomized is huge compared to the Sapphire. So the MI, little higher in the carotid endarterectomy. These are standard risk patients, not the high risk patients in the Sapphire. And therefore, if you compare this, transfemoral carotid artery stenting, it's been 15 years on the market. The CREST 30 days showed that the risk is 4.1% risk of stroke in the transfemoral carotid stenting versus 2.3% in the carotid endarterectomy. The carotid endarterectomy has some morbidity as well of cranial nerve injury that is not present in the transfemoral carotid stenting, obviously. So really it depends on, at this stage, on your favorite organ. If it's the heart, then carotid artery stenting is better. If it's the brain, carotid endarterectomy is better. On a positive note, though, for carotid stenting, that both the Sapphire 3-year follow-up and the CREST at 10 years show durability of the carotid stenting. So it hasn't, I personally have a bias that they are not as durable as reported, but this is from one patient that had type 4 stent fracture, carotid stent fracture with symptoms from trauma. All these studies, whether the Sapphire or the CREST, did not include medical management in the story. It's extrapolated from the improvement of and outcomes from carotid endarterectomy over medical management in the ACAS and in the NASCET trials. Therefore, there is an ongoing trial which include the best medical management as we currently know it, with very stringent criteria for weight management, LDL levels and A1C levels. And it's basically the CREST-2 trial. The CREST-2 trials, either patients will be randomized either between carotid stenting versus carotid stenting and intense medical management, or carotid endarterectomy versus versus carotid endarterectomy and intense medical management. This TCAR, which is the new procedure discussed today, is not part of the study. The study is enrolled, almost closing, and we are one of the centers right here. That's where I am. And we're proud to be part of this study. This is our first TCAR a few years ago. And basically it's incision at the base of the neck, proximal control of the common carotid artery, reversal of flow, and a stent placed. The Roadster 2 trial, it's a registry really. So it's not randomized, it's not controlled study, it's a prospective. And it's enrolled 692 patients that are deemed high risk for carotid endarterectomy. And what is high risk is little different than what's in Sapphire. The 30-day stroke rate is 1.9%, low mortality. So this is a great outcomes actually. And if you look here comparing TCAR versus carotid endarterectomy, you see that in the initial Roadster at when they were 219 patients, there was stroke rate of 1.4%. And in the VQI, which is the registry for Society of Vascular Surgery registry, it's 1.4%. Whereas the carotid endarterectomy, and these are high surgical risk patients. Carotid endarterectomy, there is in standard surgical risk, which is the CREST trial, is 2.3% stroke rate, and in the high surgical risk patients, which is the SVS high surgical risk registry in 6,000 patients, is 3.6%. Overall, the results are comparable and both are good, actually. When you compare TCAR to transfemoral carotid artery stenting, there is an improvement in stroke rate in TCAR versus carotid artery stenting. However, this is in the Society of Vascular Surgery VQI, which is a registry. It's not a randomized study, but there is improvement in lower risk of stroke from with TCAR. So really, if this table to compare transcarotid artery revascularization by stenting or transfemoral carotid artery stenting, the TCAR is a retrograde blood flow. This is antegrade. The anesthesia is usually general or IV sedation. This is IV sedation. The lesion is crossed. In TCAR, it's protected by flow reversal. Here in the transfemoral, it's unprotected, passing the wire. There is no catheters in the aortic arch, which decreases risk of stroke. Here's catheters in the aortic arch. The vendor here is single in the US, and here are multiple vendors. The stent design, it's an open cell, is straight, it's one stent. Here is variable. Variable vendors, closed or open cell, straight or taper stent. Specialty, most of the TCARs are done by vascular surgeons. Transfemoral carotid stent is variable, cardiologists, vascular surgeons, interventionalists of all kind. The studies here are prospective, registers or case series. There are multiple randomized trials. And this highly scrutinized study. Case selection and vendor. The company here, the vendor is involved in case selection. Here it's not, they are not involved. PRES2, which is an ongoing trial, the TCAR is not included. The transfemoral carotid artery stenting is included. There is a percentage of carotid artery, common carotid artery dissection from TCAR, around 2% in some of the studies in the mode registry, and it's probably underestimated. This is the results that I presented before about the stroke rate between both and 30-day outcomes. The cost, very much similar. The payment in the US is a little different. This is diffuse weighted MRI changes, and it shows that there is much better in the TCARs in some studies compared to transfemoral carotid artery stenting. This is a beautiful algorithm from the European Society of Vascular Surgery, recently published for management of carotid disease. However, this is the algorithm that represent my current practice. So if the patient is high risk for carotid endarterectomy is the main way to go for me. If the patient is high risk for carotid endarterectomy, then really depends on the anatomic suitability for TCAR, which is this, or anatomical suitability for transfemoral carotid artery stenting. So really, it depends largely on the patient and the anatomy. So this is a patient with a recurrent, for example, this is a patient for recurrent carotid artery stenosis after carotid endarterectomy. An attempt was made for transfemoral carotid artery stenting. You see here the wires, how tortuous arches, and then this was done by a TCAR. You see the retractors and the stent. This is a patient with significant looping in the distal carotid, so it's hard to put a protection device for transfemoral carotid stenting. The bifurcation is low, so it's not good for TCAR. That's patient for carotid endarterectomy. This is a patient with a recent stroke, high-risk region, you see this, how much thrombus and stuff in the carotid bifurcation. So that's still carotid endarterectomy. It would be the safest approach. In conclusion, TCAR has improved the results of carotid artery stenting, but only in non-randomized trials. Carotid endarterectomy remains the gold standard. Transfemoral carotid artery stenting and TCAR are good alternatives for patients who are high risk for carotid endarterectomy if anatomically suitable. Vascular surgeons need to embrace all procedures for carotid disease. Intense medical management may become the first treatment in selected patients with asymptomatic carotid disease, awaiting the CREST-2 trial outcomes, which probably expected within a year or two. Every community and country need to conduct its own cost-effectiveness analysis and set its willingness to pay threshold for new procedures, whether transfemoral or transcarotid artery stenting. Finally, if it is my neck, I want a carotid endarterectomy by a good vascular surgeon. And thank you so much. Have a great conference.
Thank you, Dr. Ahmed. And for the sake of time, I think we're a little bit late here, and we will skip the questions, and I will be happy to answer any questions for me.
One question for TCAR for Dr. Hussam. Is the stents for TCAR is different from that for transfemoral, or the same? The stents is different or the same?
The system is the whole system is the same. So the stent that comes, it's one company that makes the system for the TCAR, and they have one stent, and that stent belonged to carotid stenting in the past. It has a different name now, but it is the smart controlled stent. It was, yeah.
I think it's not only the manipulation in the guide in the aortic arch is causing the stroke, but I think also the manipulation in the common carotid artery itself before doing the TCAR, it can be a cause. How can we overcome this manipulation, or do you have any tips and tricks?
So one of the contraindications for TCAR is diseased common carotid artery. Common carotid has to be clear of disease, completely clear of disease, so that you can stick a clean artery so that you don't embolize. Yeah, I will be happy to answer any questions off the floor.
Last question. Thank you for a great session. In particular, our colleague in St. Louis, Missouri. Dr. Said, I also enjoyed your talk. How much does it cost to do a TCAR? And I'm just thinking of the low-income settings that we're in this part of the world, assuming TCAR is as good as CEA. Do you know how much it costs? Not the charge, how much it actually costs?
I really don't have an idea of how much it costs.
Yeah, because I think cost is an important consideration in this part of the world. I mean, I costed carotid endarterectomy in the UK. It was costing us about £2,200, which at that time was about $4,000 total costing. I just think that if
I am sure it will cost much more than carotid endarterectomy, simply because we do everything like carotid endarterectomy in addition to the price of the device and the stent and everything else.
Which is why I don't want young surgeons to run out of here saying, I'm getting a TCAR, and start to be doing lots of TCARs, and then in 5 years they forget how to do carotid endarterectomies, and then we have a self-fulfilling prophecy.
I will mirror what Dr. Zakari was saying. If it's my neck, please do a carotid endarterectomy.
Okay, thank you, Mr. Chairman. Thank you all, because we are short on time. I'm so sorry, because people start to sleep. So we would like to refresh him by the second for the coming session. May I invite Dr. Rashad and Dr. Elena Goronovi And Mr. Chairman, so Dr. Rashad.
Thank you. Professor.
Dr. Omar, chairperson instead of the very good. Okay.
Professor Nasser Said gave me the privilege of moderating this session and would like to have the honor of Dr. Elena Goranova, who is a professor of vascular surgery in Sofia University, Bulgaria, and she's also president of the Philippology Association of, sorry? Polcom. Yeah, you're welcome. And our co-chairpersons, Dr. Muhammad Omar Farouk, Dr. Samer Koussayer. Please. So we'll start the session. Can I call the first presenter, please? Professor Assam Al-Adi, who's Professor of Vascular Surgery at the Military Academy. He's going to talk about why should an IVC filter be removed.
Bismillah ar-Rahman ar-Rahim. I would like to thank Professor Dr. Nasser Said to give me this very great opportunity to give this presentation. Ladies and gentlemen, I would like actually to talk about a very hot issue here. Why should a IVC filter be removed? The IVC filter removal is recommended when the filter is no longer needed, as soon as the patient are not at high risk of developing pulmonary embolism, according to FDA warning and European Society of Vascular Surgery guidelines recommendations, because they may have a lot of complications. And these are the European Society of Vascular Surgery guidelines recommendation, which actually recommended that the patients who are anticoagulated for deep vena thrombosis, the routine use of inferior vena cava filter is not recommended. And this is actually class B3. And another recommendation that stated that for patients with proximal DVT who have contraindication to anticoagulation during the initial or principal treatment phase, temporary inferior vena cava filter inserted is recommended. And this level actually is class C1. So, were any FDA warning issued for IVC filter? Yes. Between 2005 and 2010, the FDA received 921 reports of serious adverse events involving IVC filter, including reports of migration, detachment, perforation, fracture, and even embolization. The FDA issued an initial warning in 2010, updated in 2014, stating that IVC filter should be removed as soon as protection from pulmonary embolism is no longer needed. Because of this complication, in May 2014, the FDA advised that retrievable IVC filter should be removed within from 29 to 54 days, nearly 4 to 8 weeks after implantation. What are the possible IVC filter complications? Patients who are left with the device beyond the encouraged removal date are at the risk of a lot of complications actually. Blood clots, severe pain, hemorrhage due to perforation, pulmonary embolism, heart failure, and even death. The possible IVC filter complication actually, there is acute and recurrent DVT thrombosis. Acute insertion site thrombosis has been reported in up to 40% of patients undergoing filter placement. IVC thrombosis, the IVC obstruction has been reported in 3 to 30% of patients following IVC filter placement related to new local thrombus formation, thrombogenicity of the device, trapped embolus, or extension of a more distal DVT. There is also recurrent pulmonary embolism, small thrombi, which are capable of passing through the patent filter or through the collaterals around the obstructed filter. Direct thrombus extension can even occur through the filter itself. The guide wire entrapment with a central line placement. When these patients try to have a central line, sometimes the guide wire and the incidence of guide wire entrapment is higher, especially from the upper compared with the lower extremity approach. There is also filter migration, and this complication and erosion and fracture, and actually these complications are uncommon. The mortality from filter placement appears to be quite low, regardless of which filter is used. As example, 3 deaths, which is 0.12%, were reported in review of 2,557 patients. When we should remove the filter? It is recommended that a removable filter be removed when risk of pulmonary embolism has passed, or if the patient can take anticoagulant. In May 2014, the FDA advised that the retrievable IVC filter should be removed within 29 to 54 days, nearly 4 to 8 weeks after implantation. I repeated actually this statement because this is a very important point here. Were there studies on IVC filter complication? Yes. In 2010, a study published by Journal of American Medical Association showed that about 1/4 of BARD G2 filter failed with device fracture. And in 2012, research study published in Cardiovascular Intervention Radiology Journal indicated that 2 devices from Gander, Tulip, and Cook Select were shown to have a high rate of vena cava wall puncture within 71 days of placement and showed a 40% migration rate. Even though the retrievable IVC filter devices should be removed after the risk of pulmonary embolism has passed, in 2013 study showed that less than 9% of devices were actually removed. This is the point which I'm trying to issue here. Very, very unusual. In every part of the world, they think about removing the IVC filter. Actually, we have a lot of indication, which is very relative indication to put the IVC filter, but nobody is thinking that we should remove this filter, actually. I think here, the percent is much lower than that here in Egypt. The same study identified other issues, including 18.3% failure rate in device removal attempt, even when they be delayed or postpone removal of the IVC filter, it would be very difficult to remove it. And even in well-trained center, the percent of failure is up to 20%, near to 20%. And 7.8% venous thrombosis event, 25% of which were pulmonary embolism. So we actually put the IVC filter to prevent the pulmonary embolism. And if we delay it to do this, that will be the cause of pulmonary embolism. How can we remove it? We can remove it by standard way using the snare and hook. And there is a various advanced retrieval techniques such as the loop, various loop snare and rigid endobronchial forceps like this picture, angioplasty balloon and exmire. And there is also surgical removal of the vena cava filter. The message to take home, This is too little indication for IVC filter, only when the anticoagulant contraindication, too much late complication like thrombosis, fracture, perforation, migration, and too limited time for retrieval, only from 4 to 8 weeks. Actually, my main message, we have to think twice before we insert IVC filter. Thank you very much.
Thank you, Professor Radi, for this very important message.
I would like to introduce Ahmed Gawish, Alexandra University Consultant, Vice President of EAVCA. The topic is, when should we decide removing a pulmonary embolus is needed?
Thank you for the kind introduction, Elena. Ladies and gentlemen, it's a great honor and pleasure to be invited to speak in the 17th chapter of the Egyptian Vascular Club. And our talk would be about when should we decide removing a pulmonary embolus is necessary. I have no conflict of interest related to this presentation. And I would start with a case presentation. We were notified to see a British lady, 60 years old. She had recent transabdominal hysterectomy, and in post-operative day 4, she developed shortness of breath and hypoxia. Her oxygen saturation dropped to 82 to 90% with oxygen mask, and on examining the patient, she had bilateral lower limb pitting edema. Actually, we were notified that she was stable hemodynamically. However, she was tachycardic with 120 beats per minute as a pulse rate. So while the ICU doctor was calling me, actually I asked him 2 questions. Did you do an echocardiography, and did you do cardiac enzymes for this patient? And this is a workflow I want to highlight, that it's very important to stratify patients with pulmonary embolism, as we will see later on. So when he notified me, I took my car and went to the hospital, and luckily, she was doing the echo, and the echo showed severe right ventricular strain, and the cardiac enzymes came out shootingly high with pro-BNP more than 10,000. So a diagnosis of submassive PE was done, and she with severe right ventricular strain and shooting cardiac enzymes. So the next step was to do a CT pulmonary angio, which showed that both pulmonary trunks were studded with clots, as we see in the angio. So our decision was, we discussed the decision with the husband, the pros and cons of intervention, because we discussed that we would use a mechanical thrombectomy device, which is the penumbra. We took the patient to the cath lab, and as you can see, both pulmonary trunks were obstructed, and we were able to retrieve some clots with the penumbra, and these were the images after the intervention. And you can see on table improvement where her oxygen saturation jumped to 97% on table. So, and she was discharged 2 days after that in the hospital, from the hospital, happy and healthy. So we know that anticoagulation works with most patients with PE, but not all patients having pulmonary embolism behave in the same manner. Although the majority can have low mortality with anticoagulation, still you have an escalating severity and mortality risk with the intermediate risk and high risk PE. So it seems justified to escalate the method of treatment according to the increased severity and mortality. Not only rely on anticoagulation. So if anticoagulation is suitable for the majority of patients with low-risk PE, we still need the TPA, for example, systemic thrombolysis for patients with massive PE, that's no doubt, and studies have shown that you can significantly reduce mortality by using systemic thrombolysis in massive PE. But what about the gray zone in between? The patients who are not having hemodynamic instability, but still they are not the so-called mild PE. And this area is the intermediate risk PE, which we have to focus on. We should stratify our patients not only on hemodynamic stability, either massive or non-massive, but there is the intermediate risk PE, which should be classified according to the presence or absence of right ventricular dilatation, the presence or absence of elevated cardiac enzymes, and also the simplified PESI score that actually looks into the blood pressure as well as the pulse taken into consideration. So the American Heart Association and the European Society of Cardiology actually provided this classification, and the essence of it is that patients with intermediate risk PE are at risk of decompensation and higher mortality, because the right ventricular strain is a marker actually for that this heart might fail, and when it fails, the patient would go into an obstructive shock, which increases the risk of mortality. So it's a marker you have to see with the echo. And not only about the acute mortality that matters, actually studies have shown that long-term PE sequelae, which we call post-PE syndrome, those patients from the pulmonary obstructive, the residual pulmonary obstruction from the post-thrombotic changes in the lower limb, we have the patients usually suffer from persistent dyspnea and impaired quality of life. So it's about also the long-term PE sequelae in those patients. This study was published in 2020, but it has many fallacies. However, they looked into the long-term mortality following these patients for 5 years. They found that intermediate risk PE can lead to increased mortality reaching 40% in 5 years. So besides having a disastrous effect on the acute mortality, it can have long-term sequelae as well as increase the long-term mortality. So are we justified to use systemic thrombolysis to extend the indication beyond the massive PE to those patients with intermediate risk PE? That was the question of the PYTHO study, which compared the two arms of patients with intermediate risk PE given systemic thrombolysis versus anticoagulation. And actually, the PYTHO study was the cornerstone, published in 2014. It was the cornerstone of all the advances made in this area afterwards, because it was able to show that you can halve the mortality with systemic thrombolysis. However, on the expense of increasing the risk of bleeding, because major bleeding actually is 6.3% in the systemic thrombolysis group versus 1.2%, which was statistically significant. So the PYTHO study provided the proof of concept that yes, mortality can decrease if we decrease the clot burden, but we need better tools. And that's why we have many toys around in the market now. The ECOS catheter, besides catheter-directed thrombolysis, and the AlphaVac, the AngioVac, all these clot removal instruments are actually evolving and progressing, and they are showing good results. And every product out in the market have done its studies, and it shows that it works, but still we don't know for which exact patient we should resort to catheter-directed thrombectomy devices. There are currently many randomized controlled trials. Most outstanding is the high PYTHO. We are waiting for the results, but the small studies are actually having encouraging results so far. But anyways, whether you have a PER team, as they advise worldwide, to have a pulmonary embolism response team where you pick these patients early on, because intervention earlier is better. But if you don't have in your hospital or institute a PER team, at least have an algorithm in your mind when you are notified about patients. Don't think about, as Dr. Assam Al-Adi added, not only thinking about putting a filter in. You have to be very cautious in selecting which patient would need a filter. Just the last line. So, because there is something to be done for a group of patients, so at least do stratify your patients with an echo and cardiac enzymes before you decide whether you would intervene or not. And finally, my take-home message, anticoagulation remains and will remain the mainstay of treatment in patients with acute PE. Clot removal can help. Selected patients can benefit from clot removal strategy, especially those with intermediate risk PE that can progress to hemodynamic instability. Patient selection is key for success, and also we are there are lots of randomized controlled trials currently ongoing. We're waiting for super selection of which patient would benefit most. And finally, still, the risks of intervention as well as costs has to be taken into consideration. So let's hope for a better future, and thank you.
Thank you, Dr. Gawish, for an excellent presentation. I hope we'll have time for discussion.
It is a great pleasure to introduce my dear Professor Ahmed Hussein. He will talk about iliac vein stenting and the day after, other hidden aspect. Please, Dr. Ahmed. Yes.
Dr. Ahmed, are you online with us? Please confirm whether Dr. Ahmed is online. Is he online?
Give me a great pleasure to introduce Dr. Saha. He's going to talk about new advance in venous stenting design. Please, yeah.
Good afternoon, everyone. And again, thank you very much for the kind invitation to speak today. And I'll be talking a little bit about venous stent design. So clearly, deep venous stenting has increased across the globe, really. On the left, you can see a patient who's got post-thrombotic obstruction. On the right, venous stent that's been placed, and you can see adequate venous return. Now, traditionally, most people who've been doing this, at least for the last 20 or so years, have used repurposed arterial stents, namely the wall stent. But most arterial stents are not strong enough for the venous system. On the left, you can see the Mathernes point with compression caused by the artery, and this is a venous stent that's been squashed in this area. On the other hand, this can be expanded with a dedicated venous stent. The key requirements for a venous stent is that they have to be large enough to be put into a venous system. They need to have strength to withstand recoil of the high fibrotic lesions and external compression that's been caused, flexibility to ability to conform smoothly in highly tortuous vessels, and durability, not susceptible to fracture even when the hip is flexed maximally. Ideally, they should be easy to deploy with precise and predictable stent placement. There are different properties of the arteries and veins which influence venous stent design. Arteries generally have atherosclerosis as its predominant diseased vessel, compared to thrombotic and compressive forces which require radial force and crush resistance. The vessel diameters are significantly larger in the veins, 10 to 20 millimeters, and again, vein flexion is much more tortuous. Importantly, the patient age can vary a lot. Patients with arterial disease tend to be older, while those who are young are in their 30s. Flow dynamics are obviously very different, with high flow in the arterial system compared to the low flow venous system. And so venous and arterial stenting are designed to meet different physiological needs. And patients who receive venous stents tend to be younger than patients who receive arterial stents. So venous stent strength. So in the venous system, you need to have crush resistance. This is the ability of the stent to withstand lateral force drops as the stent diameter is increased. This requires significant increase in wall thickness and strut width and/or diameter to compensate. And interesting, nitinol stents tend to lose their lateral strength as their diameter gets bigger. Braided designs have inherently less strength at the ends, and that's precisely where it's most needed. Here you can see a patient on the left in which an arterial stent has been placed, and you can see that it's been crushed at the femoral vein head. Here, if you have too much resistance, of course, then the worry is that you have lots of, you can get fractures, as can be seen on the left there. And so that brings us to flexibility. The iliac vein curvature is more tortuous relative to the vein diameter than comparable arterial applications. And not all stent designs can accommodate this tortuosity and may kink, which can lead to a reduction in the lumen area and/or straightening of the vein. So venous stents require sufficient flexibility to avoid kinking at physiological bends. As shown here, this is the same patient when they've been put supine. You can see the stent, which is nicely open up. But when we go to 90 degrees, you can see the amount of flexibility that's required in the stent. And this is one of the closed design stents. And at this point here, you can see an area where they were starting to see some fractures being placed. The next thing is durability. Venous stenting must withstand repeated bending, lateral and axial compression, and torsion to avoid fracture. A high percentage of post-thrombotic patients require stents that cross the inguinal ligament, as shown in the picture on the left, in a patient who's had IVC reconstruction. And this anatomical location endures the most intense bending during walking and sitting. We use computational modeling to look at the stent loading around this area, both at the ligament as it comes round, as well as the pushability of these stents. And primary stent loading modes have been done on bench testing. And unfortunately, this is not really an accurate displacement of what happens in the venous system. And the deformation modes have precedent on other anatomical locations. So where we traditionally test stents in terms of where they may be, for example in the SFA, it's very different to where the venous ligament is. And so understanding how a stent may perform, a venous stent in particular, is a challenge. And differently, we need to make sure that these stents last more than the 10-year bench challenge that's required for arterial stents, because the young age of venous occlusion patients, typically 30 years of age, may present additional considerations in duration of stent performance. Accurate deployment, of course, is a must. Stent delivery systems must enable easy and precise and predictable stent placement. Delivery systems that incorporate an isolation sheath or stabilizing sheath are preferred, and braided stents are known to shorten during deployment, which can make stent positioning less precise. The open lattice structure expanded with minimal foreshortening compared to closed cell designs, and again, this is one of the advantages of having an open cell design stent. So when thinking about stent structure, stent terminology is important. Stent design contributes to stent performance. This design includes rings and elements that are joined together in a distinctive pattern, and the rings and elements provide radial strength, while their connections play a major role in flexibility and provide longitudinal stent. And thinking about these two, it's a trade-off. So cell geometry is a trade-off between stent flexibility and surface coverage. And venous stents can be designed with either an open or closed cell configuration. Open cell stents are those where the adjacent elements are periodic peak-to-peak connections and peak-to-valley connections, and mid-strut to mid-strut connections. In contrast, closed stents are those where the adjacent elements are fully connected at each crown, and braided stents may be considered a closed cell stent design. These connectors play a major role in stent flexibility and provide longitudinal strength. And fewer connectors may make the stent more flexible, while more connectors make the stent more stronger. Distribution of these connections, though, is key to achieving a balance between strength and flexibility. But does it really matter? We looked at 6,000 patients in the published literature in 2022, and we looked at the one-year outcomes in these patients, comparing dedicated versus non-dedicated stents. And interestingly, the primary patency between dedicated versus non-dedicated stents was very similar, as was the secondary patency. When we looked at our own data of 200-odd patients that were treated in our centre, either with an open cell stent or closed cell stent design, it actually had similar outcomes in both sorts of designs, although there was a tendency for the closed cell stent design to fracture under the ligament. Technical success or technical problems were the #1 reason for stent failure. So it wasn't about the tool, it was about how we were using that. Together with flow and patient thrombotic factors, these were more important than the type of stent that we were using. And as it says, a bad workman always blames his tool. I think in venous stenting, this is very important. So the 4 key factors of success are not about stent design. It's about using the right patient or selecting the right patient, having the right imaging, having the right kit, and doing the right surveillance of these patients if you are going to have very good outcomes. Thank you very much.
Thank you, Dr. Saha. Very nice and inspiring presentation. And now Professor Ahmed Hussein is actually online. That's very good. Welcome, Professor Ahmed Hussein. Professor Ahmed Hussein is my colleague for a long time. He's Professor of Vascular Surgery at Shams University. He's going to talk about venous stents and the day after. Please go ahead.
Good afternoon, Dr. Rashad and the rest of distinguished colleagues, and thank you, Dr. Nasser and Dr. Assam Qadi for the kind invitation. I would have loved to be in person with you, but unfortunately some compelling family commitments prevented me from doing so. My previous distinguished speaker has made my job probably a bit easier. Actually, the two presentations are quite interrelated. That's my agenda, and I'm going to be focusing on aspects of biocompatibility. Well, when we talk about the day after stenting in general, not only the iliac stenting, which is the focus of many interventions in endophlebology, because it simply determines the fate the day after. In fact, within the few minutes after deployment of any stent, the current status for the venous stenting is that it has been growing for like the last decade or so, and advances in the both the tools and the stent design, as you have just heard, has led to like a sort of nearly a revolution in vein stenting, especially in the iliac territory. However, in the absence of adjuvant pharmaceutical support, a stent definitely is liable to fail. We are talking really about sustainability of the initial technical result. Without the adjuvant pharmaceutical support, sustainable biocompatibility is really sort of elusive. So one way or the other, stents have to be assisted. You all know better than me. After deployment, we have gone through this several times before, and we are witnessing more and more refinements of the stents on the venous side, whether directly or post-catheter-directed thrombolysis, which we practice with variable workloads, of course, but iliac stents and venous stents are here to stay, of course, in special, clear indications. But keep in mind always that a stent is liable to negative remodeling, inherent hyperplasia, and thrombosis. What is really the underlying mechanism? If we get a deep dive into the moments after deployment of the stent, we'll see that often there's an activation of the coagulation cascade. We're going to see right now. A stent could be liable to either thrombosis, stenosis, fracture, or migration. Why is that? Let us define biocompatibility initially. Biocompatibility is simply the surface interaction between the metal of the stent and the blood vessel. Not only that, because stent is not deployed in water, it's deployed in blood. Therefore, we may come to another definition. It's an interaction of the implanted prosthesis with the human body or the body fluids, or the blood device surface interaction. The concept has evolved over the years from causing no harm to doing good. That is encouraging positive healing response. Once the stent is deployed, in the first few seconds, a hydraceous layer forms, and that triggers cellular invasion with the inflammatory response and inevitably activation of coagulation cascades, both by the mechanical effect of deploying the stents and the presence of the metal. The mere presence of the metal is there and there to stay. And I remember quite well in a discussion, inter-discussion with Professor Raju, like 4 years ago in one of the congresses, that once we deploy the stent, we get rid of the mechanical element, stenosis or occlusion, be it post-thrombotic or May-Turner or whatever. However, the inflammatory element is still there. And hence the rationale of using, again, double protection, antiplatelets and anticoagulants. I know quite well that the best practice guidelines, evidence-based of course, did not reach a clear recommendation as far as the dosage and duration of antiplatelets or antipatient anticoagulants, and there's no consensus. And I do hope that within the subcommittee of Egyptian guidelines for the vascular and endovascular practice in Egypt, hopefully soon will come and touch base on that. Happens. Does that have an impact on patency? That's the $1 million question. Indeed, so many trials, not all of them are RCTs. However, lots of meta-analysis again and published papers have shown that there is an intimate correlation with patency at 6 months and 1 year. Therefore, my take-home message number one is time and again, stents have to be assisted pharmacologically. The problem might be compounded because sometimes there's an overlap between two different types of stents, which is still being practiced. Probably that's not preferable. And again, protrusion of the iliac stent in particular for like a couple of millimeters or 3 millimeters is now probably less and less being practiced from fear of encroaching on the contralateral side. As far as our registry, in the 11 years till 2021, in both hospitals, in specialized hospital and in Bangladesh, as well as another university where I'm privileged to be supervising the vascular program over there, Aswan University. That's the registry, but let me focus on the venous stents in particular, with a variable follow-up between 14 and 76 months. We have had our share of different complications, not so many, thank God. However, they can occur from 8 months up to 3 years, and the determinant factors are multifactorial. And we were able to identify from that pool 2 groups, and we looked after the outcome for group A, antiplatelets with anticoagulants, and group B, anticoagulation alone. And to tell you the truth, the outcome was not statistically significant as far as patency, primary patency I'm talking about, in both groups. However, quality of life questionnaire, which was well designed at the time, was much in favor of having both antiplatelets and anticoagulation. And the last quarter of last year, I was with the Pittsburgh team, Dr. Macroon and Shar and Islami, and over there, once the iliac stenting, whether for the May-Turner or post-thrombotic, they usually, when the procedure took more than 1 hour, they are with within the practice of putting double antiplatelets and anticoagulation, at least anticoagulation for the first couple of months. Of course, we may debate about that. However, these were some of our cases, and before and after. I'll go quickly for the sake of time. And this is another case which, with the rest of the team, we operated upon 10 days ago. That has, of course, I'm talking about especially this portion, which again shows that there is definitely an element which is hemodynamics, and this is really pathognomonic, the transpelvic collateral. And it has resulted actually in that particular young lady in a pelvic congestion syndrome. And again, I'll try to be as quick as possible. I'm sorry for that, technical problems. So I'll come to the second and last take-home message. Again, the literature is so convincing about the need for adjuvant pharmacotherapy once the stent is deployed. What about future trends? Further improving in the stent material is quite expected with new alloys, and the definitely of open cell design is much favorable right now. I do not see a horizon so far for the bioresorbable stents. However, again, several teams are working on that, and a couple of trials were really convincing for those of you who would like to come back to the literature. In conclusion, ladies and gentlemen, venous stents are liable to all stent post-deployment complications, and currently no single stent is 100% biocompatible. Consequently, in-stent thrombosis and occlusion remain a potential threat, and anticoagulation probably in the first 6 to 12 months, again, that is debatable. There's no widespread consensus on that, especially low molecular weight heparin in the first 2 to 4 weeks, actually not 6 weeks, and maybe DOACs later on, be it 3 months or 6 months. It depends on the background of the case, the cause of the iliac stenosis or occlusion, and the complexity of the anatomical lesion. Again, no consensus regarding post-procedural antithrombotic therapy, and definitely further research is warranted. And last take-home message, we should all follow the proper indications. Adjuvant pharmacotherapy is a must. Anticoagulation with antiplatelets, probably that's more trendy right now, not to speak about strict recommendations. And careful regular follow-up is mandatory, especially in high-risk patients, obese or malignancy. And we have to ensure always the sustained biocompatibility. I thank you for your attention.
Thank you, Professor Ahmed Hussein, for the nice presentation. This was well received. And now we have a few minutes for open discussion. And it's my pleasure to moderate the discussion together with my co-moderator, Dr. Elena Goranova. The chairpersons, if you please, if you have any questions or discussion, it's open also for the audience. I would like to start with asking Professor Assam Al-Adi, if you please come to the podium. You gave us a very clear message about the importance of having good indications to put a filter and be very cautious, and also about the importance of removing the filter as soon as the indication is removed.
Yes.
The problem with this is that very few, I think, of us have actual experience and training in removing filters. And I would like to ask the audience how many of us have actually removed the filter. Could you raise your hand? Not many. So do you do anything?
That's much larger number than I was expecting, actually. Yes.
So do you have solutions for this?
The solution that we have trained our junior to do this. We have to put a policy. We are now starting to put a guidelines for the Egyptian vascular practice here. We should put this in the guidelines, and we should put this in the training of our candidate to get the vascular MD or the Egyptian Vascular Fellowship. We should concern this as a senior surgeon in our practice.
Thank you. Any questions?
It's just a word of caution, because most people we put an IVC are trauma patient, young patient. The problem is they got lost for follow-up and they don't show up after a couple of years, too late. So my advice is don't put the filter unless you have an extreme indication for that. Because unfortunately, most of them we lose them. They don't come to,
Exactly.
for treatment.
This is the main issue is we have to think very carefully before we put IVC filter.
Go ahead, please.
Thank you, Professor Assam. It's a brilliant presentation and very important message that we have to be very cautious in putting filters. The patient has to earn his filter in order to put a filter in. But one thing during the discussion, having talked about the guidelines, is that what I feel is that you want to have that if you put a filter in, you have to get it out.
Yes. This is the guidelines.
This is not my opinion, actually.
Yeah, but I think
this is the guideline.
I
should
think-
be removed within from
Yeah,
4
should-
to 8 weeks. That is what did the FDA said. That is what the European Society of Vascular Surgery said.
Yeah,
And actually, I was in UK in my training 27 years ago, and we have very strong message from NHS that this filter should be removed whenever you can remove it. However, in that time, most of the IVC filter available was unretrievable.
Yeah, cannot agree more, but however, I'm thinking about if you put it as a standard, maybe the risk of removing the filter, because removing a filter is not easy.
I know.
So the risk, if the risk is higher than leaving it, and with the risk of developing maybe...
That's definitely, actually, it is my indirect way to stop the abuse of IVC filter insertion. That is the point.
We should do this meeting in a cardiology meeting.
Yes, definitely.
Can I just
Thank
add
you,
something a little? So if you are in a situation, you put it a filter, and unfortunately later on has total thrombosis in the filter. So how can you manage a case like this? First, you will sink to treat the thrombus, and later on you need to remove.
Exactly.
How can you manage something like that?
All the studies actually in this is making very difficult, but they start with thrombolytic therapy actually to thrombolysis the thrombus, and they try to remove it. It's very challenging, as Dr. Ahmed said.
I had cases like this, and if they come early, can do catheter-directed thrombolysis, and they respond well 2 weeks, 14 days, and then anticoagulation for indefinitely. Please.
Since we're in Egypt, I'll give you a piece of history. Many years ago, Richard Nixon, when he came here en route from Israel, he got a DVT and a pulmonary embolism. I don't know if you know that, whilst he was here. And he was flown back in Air Force One to Bethesda, Maryland.
Who was that again?
Richard Nixon.
Oh, yes, Richard Nixon, yes.
He was flown back to Bethesda, Maryland, where he had an inferior vena cava plication, from which he almost died of hemorrhage. So I think the indications for caval filter, there are good indications. There's been a recent randomized trial, just last week came out. If you have a major VTE and you have an absolute contraindication to anticoagulation, or you have a demonstrated pulmonary embolism despite adequate anticoagulation, you will benefit from a filter, and this paper showed it. You need to take them out. Anything else? Dodgy. Trauma, there have been randomized trials with caval filters in trauma. It does not show any survival benefit or reduction in P, even with the removable filters that come out. The problem is that people are putting them in and forgetting about them.
Exactly.
Yeah.
This is the point.
Yeah.
Thank you for your comments, always very useful. Thank you, Professor Assam Al-Hadi.
Okay.
And now Dr. Ahmed Gawish, please come on the podium. Dr. Ahmed Gawish.
Ahmed, bearing in mind that pulmonary embolism is the major killer, what is the longest period that you perform thrombus removal?
Yeah, that's an excellent question. Actually, the decision to do a thrombolysis, to remove the clot, largely depends on when does the patient start showing signs of decompensation. Because we cannot advocate, at the current being, we cannot advocate removing a pulmonary embolism for all patients. If the patient is hemodynamically stable, if the patient doesn't show any signs of right ventricular strain or elevated cardiac enzymes, there is nothing that would say that he would benefit from going in. So it's actually not about the timing from the episode that mandates intervention. It's how the patient would behave within the first 48 hours after the insult. Usually, this is the usual period of starting whether the patient will continue as a non-fatal minor PE who fares well with anticoagulation, or he will need intervention, whether he is going to hemodynamic decompensation or shows signs of right ventricular stent. So actually, it's not like the DVT when we say 14 days is the golden days for intervention. It's usually about the patient situation. Yeah, if that answers the question, there is no, of course, the earlier the better. They say there was a study that showed that intervention with starting showing signs within 1 hour shows that 90% would improve and have good prognosis. And another study for 12 hours showed the same benefit. But actually, some people within 48 hours, you can have pretty good results. More than that, there is no published data.
Thank you. I have a question for you. As you know, the guidelines call for systemic thrombolysis for the indications you mentioned, like low blood pressure and impaired right ventricular function. But you showed us a case of mechanical thrombectomy. How would you select between catheter-directed thrombolysis and mechanical thrombectomy, or maybe both?
Yeah, the systemic thrombolysis, the high-python study was the cornerstone. It showed it actually works, but with a high risk of bleeding. For catheter thrombolysis, they do sometimes the pigtail thing, to go with a pigtail and fragment the clot with thrombolysis. I don't have a personal experience in doing thrombolysis for PE, catheter-directed, I mean.
I'm sorry, I meant systemic thrombolysis versus thrombectomy device.
Yeah, systemic thrombolysis for intermediate risk PE is not indicated because you have halving of the mortality risk. However, it's 3 times the bleeding risk. So giving systemic thrombolysis should be restricted for patients with hemodynamic instability. If the patient blood pressure drops down, the patient is shocked, you are allowed to give systemic thrombolysis with the intention to avoid mortality or limit the mortality. But for intermediate risk PE, when the patient have a stable blood pressure and stable hemodynamics, this is not an option because you expose the patient to a very high risk of bleeding.
Very good. Any other questions?
لا لسه هيجي دور عشان يسألوني سؤالين وخلاص وقف.
Dr. Saha, please.
لا.
Thank you very much, Dr. Saha, for a great lecture. I'm more interested in the clinical part of it. I have used non-dedicated venous stent in iliac vein, and I have used dedicated venous stenting. Is there any paper that showed a clinical benefit of the specific venous design of a stent? Better radial force, open cell design on both ends, and closed cell design in the middle. Is it different from Boston wall stent, who result with the American registry? Can you say to the hospital manager, I need this stent for that clinical benefit? And thank you.
It's a very good question. I don't think there's enough data out there that showed any potential benefit of one stent design over the other. I think the Achilles heel right now is the inguinal ligament, and I think all of our stents fear that the most. There has been some evolution of using braided stents now. There's a blue flow stent specifically designed for the inguinal ligament, but I think that's really the problem right now. What we do know is that technique is very important, and I think that the failure of stenting is largely based on the technique as opposed to the stent itself. And making sure that we do have good technique is paramount.
I think I totally agree. I think the clinical decision making, when to put a stent, from which part to which part, is more vital than the type of a stent. Would you agree with the conclusion?
Absolutely.
Okay, I agree.
I think Dr. Gawish has a comment.
Dr. Saha, thank you for an excellent presentation. Now you showed us two studies which were very, very nice. One of them, systematic review that you've done, dedicated versus non-dedicated, and the other one was your data regarding using venous stenting. So you concluded that they all work, and they are all good, and they both have comparative results. So do you agree that the coming challenge in the venous stenting technologies would be for the infrainguinal segment rather than getting a better stent for the iliac segment. So given these data, or what do you think about that?
I think, firstly, the current challenges are still at the inguinal ligament and making sure that we have something that that works there effectively in the longer run. And I still think that we have a paucity of long-term data for these young patients that we really need to understand. But you're absolutely right, the FemPop segment is still a big challenge, and understanding what to do there is still an unknown. And in the systematic review, I looked at the papers that had stented or angioplasty the FemPop segment to try and improve the inflow. And the truth is, it still doesn't have a great impact on the outcome. So I think it's about making sure patient selection is still very, very important with our current technologies. We ourselves have thought about fistulas and phlebectomies, a variety of different adjuncts, but none of them have been satisfactory enough to give us adequate patency. So I think there's a lot more to do.
Thank you.
Last question, please.
I see that the big problem as regard the insertion of caval filters and venous stents. Can I dream, and there is something in evolution, to invent such filters and stents, which is, we call it, disintegrates by time, I mean absorbable in the future time, because of your experience as regard these things?
Yeah, I think one of our speakers alluded to the fact of biocompatibility and the lack of biocompatibility. The truth is that would be an ideal, wouldn't it? If we leave nothing behind and we keep the vein open. Right now, I don't think we have enough technology available. There's an interesting company that have got an AV fistula and a coronary artery bypass graft that have just had 30-odd million pounds of venture capitalist funding to bring that through as a scaffold. But again, we don't know what will happen in the long run and whether there'll be stenosis, intimal hyperplasia to those areas. But that would be a lovely ideal, a biodegradable thing that goes away, particularly with the filters. There have been some filters that have been designed to do that, but none of them have really come into the clinical arena that I know of.
Thank you. And with this, we conclude this session. Thank you for all the speakers for their excellent presentations. And thank you to my co-chairman. We're honored. Thank you. Thank you all.
For the sake of time, I can see a lot of tiredness in your eyes, and I will be quickly moderating the next session. The next session, we have a guest which are very eminent intervention radiologists from the Middle East. Unfortunately, none of them were able to attend, but they have provided a recorded lecture. So I will provide you with a taste of venous intervention, not from background of vascular surgery, but from background of intervention radiologists. Let us start the first recording, which by Professor Mohammed Al-Maiqil. Mohammed Al-Maiqil is an eminent intervention radiologist from the Kingdom of Saudi Arabia. He has a lot of series regarding venous practice. He will give us a talk about varicose vein update, about thermal and non-thermal ablation. So we'll have the recording now. We'll keep the question till the end of the sessions.
Assalamu alaikum wa rahmatullah. My name is Mohammed Al-Maiqil. I'm a head of intervention radiology in National Guard in Riyadh. Thanks for the kind of invitation. My talk will be about the varicose vein update in thermal and non-thermal ablation. I have no conflict of interest. So the endovenous ablation, we have the thermal and non-thermal endovenous options. The thermal ablation, the most famous are the laser RF. Then we have the microwave, steam, and HIFU. For the non-thermal, we have the glue, the MOCA, the old gun, the ultrasound-guided foam sclerotherapy. We have the Varithena, the PEM. And recently we have the MOA, the mechanical-only ablation. So what are the differences between the thermal and non-thermal ablation? In case of thermal ablation, tumescent is mandatory because of the multiple needles, pain and discomfort is encountered by the patient. Stocking is mandatory and advised. Therefore, and the nerve damage therefore increases. However, for non-thermal ablation, no need for tumescent, less pain and discomfort. Maybe MOCA is a little bit painful during the operation of the MOCA. No need for stocking in case of glue, and there is less likely increased risk of nerve damage. The pattern of the reflux has been published in multiple publications, including this old study, segmental, multi-segmental, diffuse or axonal. This interesting paper shows the pattern related to the malleolar reflux. There are patterns not being reported, like the dealing with synechiae and adhesions in case of history of thrombophlebitis. What will be the best option? Maybe it's according to the experience of the operator. There are also patterns encountered and not described in the pattern of the saphenous reflux, where you encounter multiple channels of saphenous veins instead of single channel. Now, for the approach, as everybody aware, we have multiple options: puncturing above the ankle and treating the whole vein, coming from above retrograde fashion, only ablating below knee, or even retrograde and antegrade approach at the level of the knee. How about as endovascular specialist using DSA and fluoro? This is a case of from my collection where I have to use the DSA and the fluoro because of the very tortuous high-risk patient, saphenous vein. So I punctured mid-leg, and then using a catheter and wire, I managed to go all the way to the saphenofemoral junction, and I managed to treat this patient with the MOCA. The laser, now we have multiple options in the market: total vein system, Dornier, Medtech. In the Gulf area, we have the most famous is the VenaCure and Biolitic, where we use a slim and double radial fiber. Now, recently, there is a new machine came up from Biolitic using 1940 instead of 1470. And there is a note that the water absorbed at higher level, at level of 1940 in comparison to 1470. What are the advantage of 1940? In this paper, there is 7 to 12 times more effective than the classic 1470, with less pain, less risk of paresthesia, and even less need of amount of tumescent anesthesia. How about treating bigger saphenous vein? This is a paper where they publish 261 patients treated with radial fiber and a diameter of 2.4 with occlusion rate of 98%. It's a short follow-up, but it's kind of interesting not to exclude those type of patients. How about the concept of endocrossectomy and flush occlusion, where you don't leave 2 centimeter or 3 centimeter from the junction? 135 patients of GSV treated with occlusion rate of 88%, minimizing risk of new vascularity. Long follow-up, 10 years follow-up in 240 patients. 85% of them completed 10 years follow-up with the recanalization rate only 0.5%. 21% of patients needed additional therapy in case of GSV. How about option of RF? We have multiple options also in the market. Vein close, where the ablated zone is reaching up to 10 centimeter. To my best knowledge, this is the longest landing zone where you can ablate at one time 10 centimeter segment. Therefore, the time of procedure is much shorter. We have the thermoblock, with 5 centimeter zone of ablation. We have the vein clear. We have the Medtronic famous closure fast and RFS. We have the F-care where only 0.5 centimeter zone is ablated. However, the pulling time is much shorter in 6 seconds. In longer term, using RF, this is a study with 15 years follow-up with 88% no recurrence at the ablated vein. This study, they treated GSV, they treated also SSV, anterior accessory, and Giacomini. How about glue? Glue published, and the first publication came up in 2013. We have 5 systems in the market. We have the VenaSeal, the American glue. We have the Turkish, very close, where the microcatheter has multiple side holes. We have the VenaBlock, where the catheter tip has light. We have the Venex, very similar to VenaSeal. And recently we have Venecto, the Swiss F-care system. This is in summary the zone of or the junction where you leave it, where you leave the catheter from ranging from 2 centimeter to 3 centimeter up to 5 centimeter, and the rate of pulling in each company. Rate of thrombophlebitis in glue is very common, up to 20%. And patient need to be treated, as this is the most common complication. How about thrombus extension? This is reported rate up to 5%. Luckily, most of these patients can be treated with only anticoagulation from 2 to 4 weeks with no risk or no increased incidence of DVT. But it's need to be aware, need to be discovered early. In the recent publication, there are more and more cases where they discover there is a granuloma from the glue. It has to be excised. This is a case report. This is the first one. He's the first one who published in 2020, ended up with the excision of this granuloma. Another publication also before 2 years with the granuloma because of the extravasation of the glue. So operator has to aware of to minimize risk of spill and extravasation. Another publication also where the granuloma has to be excised because of the increased risk of infection. Infectious thrombophlebitis also could happen and need to be diagnosed early. This patient unfortunately ended up with excision of the saphenous vein. Moreover, also case of septicemia also being reported. So doing the procedure in full aseptic technique is very important. How about comparing with glue to RF? This is a small study with 5 years follow-up, very similar in case of recanalization. RF in comparison with the glue, larger patient with midterm follow-up. Occlusion rate is very similar. Surprisingly, risk of phlebitis more in RF cases. 3 cases reported with glue, granuloma, and clumps ended up with excision. 1 case has a thrombus extension treated luckily with only anticoagulation. No reported case of DVT. Comparing glue with laser, retrospective study, 150 versus 189, similar occlusion rate.
Okay, we'll thank you, Professor Mohammed Al-Muayqil. And now we move to the next presentation by Dr. Karim Abdeltawab. He is going to talk about treatment of female genitalia varices.
Rahman Rahim, Assalamu alaikum. Actually, it's my great honor and pleasure being here today with you in this elegant meeting, and I'm so sorry I couldn't be in person. I am Karim Abdeltawab, the PERS secretary, and today I will be talking about the management of the external genital varicosities in females. I have no relevant financial disclosure. To introduce, I would like to say that the eye doesn't see what the brain doesn't know. So we have to be familiar with this condition. As we are talking now about a very common problem, commonly associated with pelvic congestion syndrome, whether vulvar, perineal, and less commonly inguinal and buttocks alone, or associated with lower limb varicosities. This can occur due to various reasons, like reflux, obstruction, high pressure, or genital venous insufficiency. So, is this a common disease? The answer is yes. This is a very common disease. According to Hobbs, about 5% of females in childbearing period suffer vulvar varices, and this percentage rises to about 40% in women with pelvic congestion syndrome who are typically multiparous in childbearing period. So let's see the relevant anatomy. Pelvic venous anatomy in women is extremely complex, as we all know. We all know there are 6 escape points or leak points communicating the lower limb with the pelvis, namely perineal, inguinal, obturator, superior and inferior gluteal, as well as clitoral. This can spread either ipsilateral or contralateral due to the fact that there are no valves in the pelvic and genital veins. Let's run quickly through the diagnosis. We have the history, physical examination, and imaging. About the history, the most important is pain. All sorts of pelvic pain can be seen. Lower back pain, lower abdominal pain, coital aches, genital pain, also continuous genital discomfort and arousal could be seen in most of these patients. So, what if the patient is only complaining of lower limb varicose veins? We should always suspect leak points if we have extra axial varicosities, not going along the course of the great and short saphenous veins, especially if there is no reflux in the saphenofemoral or saphenopopliteal junctions. As for imaging, vulvar, perineal, and gluteal ultrasound should be thoroughly done in patients with pelvic congestion syndrome before and 2 weeks after gonadal embolization. So always ask the patient to strain to assess reflux. So how to treat? We must treat gonadal and iliac reflux first. So if we have pelvic congestion syndrome, this has to be treated first. As you can see in this case, this is the left side, embolization of both gonadal and iliac reflux. And here we can see the injections in the right side. So we always treat before the genital varicosities, we always treat the pelvic first. After treatment of gonadal veins, we do either surgical ligation, which is a rather odd procedure nowadays, or we do sclerotherapy, which can be done either on ultrasound guided alone, or like this case, here we can see, I will show you a case. This is a case of ultrasound guided sclerotherapy. We see by ultrasound, and we just go with the foam sclerotherapy, 1 or 2%, and we inject it directly, as we can see here, guided by ultrasound. So this is the first method of sclerotherapy. The second is our new combined ultrasound fluoroscopy technique, which is highlighted in the current issue of Interventional News, which is the combined fluoro and ultrasound guided injection. As for the anesthesia, as we all know, the vulva is very sensitive. So if patients have planned the vulvar puncture, always we should do pudendal block first. Consequently, in patients who need perineal, gluteal, or inguinal punctures, subcutaneous local anesthesia is usually sufficient. What what we use with the tools and sclerosant, we use 1 or 2% etoxysclerol and an 18 gauge cannula in most of cases. Sometimes I use butterfly. Here we have the procedure. I'm going to show you a complete case of our new technique. Here we can see the valvar varices. We already did our pudendal nerve block. This is a 31-year-old patient suffering from marked genital heaviness. And guided by ultrasound, we magnify and then we enter a big varix, and then we inject contrast media. Here you can see injection of contrast media, and here is the venography. We can see massive valvar varices going both sides. Now the usual Kassari method, 1 to 4 as usual, and then we inject it in a pulsatile manner, as you can see here. And here we can see pushing the contrast medium to fill all the valvar varices bilaterally, and then we take a control venogram. So as you can see here, nothing is going to the vulva. And very importantly, here you can see by ultrasound the sclerotherapy, the etoxysclerol is going all through the varices. So we need to do very good compression for 5 minutes at least after the procedure. Post-procedure, we need to do good compression for 3 to 5 minutes with tight underwear and hot fomentation. Then we discharge the patient. No specific medication is usually needed except for analgesic medication. Follow up by ultrasound till 12 months. We do it 1 week, 2 weeks, 6 months, and 12 months after treatment session. So let's see our results in the first 70 cases published in AJIR. Please take a minute to scan the code. This will take you directly to our paper. Now, actually, I have more than 160 cases, but these are the results of our first 70 cases. We have 100% technical success and almost 100% clinical success, with 20% of patients needing a second session after residual in follow-up. Almost no complications at all happened in our patients. No major or minor complications happened. All patients on venography of the draining veins showed drainage of the valvar varices into the pelvic veins, mainly the internal iliac veins, through mainly perineal and internal pudendal veins. That was the commonest. As you can see here, the internal iliac veins, valvar varices draining through the pudendal veins. Almost all cases showed drainage in pudendal vein as commonest, and to external iliac was the rarest, with only one puncture revealing external iliac. We can see here cases with communications through pudendal, vaginal, and inguinal. Like the lower left image, this was going through the inguinal vein. Also, valvar punctures filling.
Thank you, Dr. Karim Abtawa, for your nice, informative, and illustrative subject. And now we move to the second speaker, the next speaker, Dr. Muhammad Badran from Jordan, and the subject is venous malformation, how to treat.
Okay. Hi, good morning or afternoon. Thank you for the invitation. I'm going to talk about the management of venous malformation. Just to start with, the vascular malformations are divided into two big categories. The vascular tumors, the most common one is the infantile hemangioma, and then the malformations, which means abnormally formed cells, either low flow, capillary, venous and lymphatic, or high flow, which is the arteriovenous malformation, or a mixture of all of these. Today, we're going to talk about the venous malformation and maybe a subtype of it called fibroadipose or fibrofatty vascular movement. So the venous malformation are generally blue to green lesions that can affect any part of the body from top to bottom, and usually they are become bigger on more dependent position like this lady over here. And this is just a quick look at the difference between infantile hemangioma in a child and a venous malformation in an adult. Obviously, this type of work needs teamwork. This patient, for example, has extensive venous malformation of the left upper limb, and despite having 10 sclerotherapy sessions, there was no significant difference in this patient. Requires a combination of compression therapy as well as chemotherapy by sirolimus or rapamycin. This patient has associated limb-limb discrepancy, and that requires the interference of our colleague, the orthopedic surgeon, to make the leg length equal, while this patient with FAVA, fibroadipose vascular anomaly, did not respond, and this requires surgical resection. A common thing that happens with venous malformation is localized intravascular coagulopathy, LIC, which if not treated can develop into DIC, disseminated type of intravascular coagulopathy. The most common thing in these patients, they get high D dimer. And the reason for that is that the flow within these lesions is usually slow. And because of the slow flow, the coagulation factors are consumed, and this will result in coagulation cascade, which later on can worsen to lead to DIC, especially with surgery, infection, and significant sclerotherapy. And this can be prevented by compression therapy before and after treatment, and by giving Clexane before and after the treatment for about 1 week before and 2 weeks after. And this is one example of patient developing localized intravascular coagulopathy within the tongue, treated by low molecular weight heparin, Clexane. When we treat, the most common ones I use for sclerotherapy is polydocanol or STS. I use also bleomycin. We can use anything else. I use alcohol, glue, onyx. If I treat and there's a large amount of disease involved, afterwards I like to give patients Clexane, low molecular weight heparin, especially if the patient has venous lakes, to prevent the potential of thrombosis after the treatment. There are several types of venous malformation. Varicose type looks like varicose veins, and this is MRI for this patient, and a venogram, and you can see this big vein. And to treat this, looks like similar to varicose veins. So this is a catheter from top and bottom, treating this with glue, followed by polydocanol, and a venogram confirming patency of the normal veins, and we follow with giving the patient stockings. This patient with varicose type of venous malformation with aneurysms, multiple catheters, and then a venogram, followed by laser therapy in the venous TVLT, and then polydocanol form, and after that we're going to put compression like varicose veins. This type is varicose type, but extremely large, and a patient like this, if you inject or do whatever, it's not going to work. Of course, we're going to do a venogram to make sure that the deep venous is good. And this patient, we put laser in the venous laser from the inside, and that wasn't good enough, so we treat the patient with radiofrequency ablation, the same one that we are used for the thyroid, and followed by polydocanol, and that gave very good results. Another varicose type in the rectum. You can see this area here around the rectum on the MRI. When we inject, this is going to the inferior mesenteric veins. We have to protect it, protect the portal vein. So we injected glue first, and this was followed by polydocanol form and some bleomycin to improve the efficacy. When the lesion is extensive and involves the deep system, we need to do a venogram. And if you see here, this is involving the popliteal vein. And to treat this, this is a venogram again. And we start from far away, putting a catheter here in the popliteal vein to know where it is, and gradually filling this space with glue until we fill it and isolate it from the normal vein, and then putting polydocanol foam. And this is venogram confirming patency of the normal vein. This patient with venous malformation, varicose type, but with fat atrophy. And here is the vein underneath showing reflux. And we do a venogram, direct puncture. This is followed by putting a plug to prevent the glue from going to the deep veins, some glue as well as polydocanol foam. This patient, varicose type, close to the perineal vein. If you're going to do this, expect to have problems. This patient, we injected glue. Unfortunately, it migrated, so be prepared to either snare it or aspirate the glue away. And follow up MRI, good results. The other type is sponge, and this is a sponge type within the forearm. Multiple needles here. There's a big draining vein, so we're going to put some glue to prevent the foam just to go to the deep vein, and after that, polydocanol form and then compression. Another type sponge, and here a combination of polydocanol and bleomycin with significant reduction after treatment. Another sponge type, but if you notice here on the MRI, there's a big blob here next to the urinary bladder, and this is a thrombotic stenoiliac vein. And when we do a venogram, we can see that these are important collaterals. We don't want to block them, so we're going to do sclerotherapy elsewhere. Another sponge type before with treatment and good result after. We'll go to the lake type. You have very large veins. You can see these in the ultrasound. And here, puncture. I'm going to use here a combination of alcohol followed by polydocanol and then immediate compression. And after that, you're going to put compression, and there was a good result clinically. This is a lake type within the back. Whatever you do is not going to work, so you have to do something else. And here we did laser, and like other case, like the radiofrequency ablation, followed by polydocanol foam, and then this is a follow-up MRI with good results. Here, the lake type here is affecting the knee joints. We have to be aggressive in treating this because it can affect the knee, and here's irrigation of the knee. This is to prevent the premature osteoarthritis. This is lake type, treated similarly, multiple puncture techniques, compression during the treatment to get the blood out of the system, followed by glue and polydocanol foam. And this patient has a lesion in venous malformation in the neck. You can see that when you puncture, you'll see that it's going directly to the deep veins. That's not.
Thank you very much. Sorry we couldn't have the full time of the video, but all the lecture of the meeting will be online on our YouTube channel. So with this, we end the session number 16, and we'll go straight away, session number 15, so we'll go straight away to session number 16, which is titled The Cutting Edge of Artificial Intelligence in Vascular Surgery. There will be 2 lectures. One of them, Professor Munir Nazal, he is a vascular surgeon from Toledo University in Florida. And the other one is Professor Konrad Karz, who is a vascular surgeon. He's specialized in pediatric transplant from Germany. So it sees that both of them are vascular surgeons involved in AI. And I will have the next lecture. So we'll start by Dr. Munir Nazal. You will have the live recorded. Go ahead.
I would like to thank everybody in the Vascular Society of Egypt and invite me to this meeting. I would have loved to be there in person, but unfortunately, it was difficult to achieve that. The topic today we are going to handle is artificial intelligence in medicine and its expanding role. Medicine is not going to be any much different from any other specialty when it comes to artificial intelligence. Actually, preparing those slides, I was helped by artificial intelligence in PowerPoint. Netflix, which everybody part of nowadays, and Amazon is also artificial intelligence. That's what PowerPoint gives you ideas to do your lecture. We'll cover a number of fields, but for the sake of time, we'll focus on issues related to medicine. And why do we have to go into artificial intelligence? Very simply, because there's a huge amount of data. We don't know what to do with it. And only supercomputers can analyze this data to get the benefit out of this data. It is an expanding role. It is actually giving the computer the brain mind of a human being in order to give answers that the humans are looking for to help humans in their development and evolution. The use of artificial intelligence in medicine is an issue of great interest, and we cannot stop thinking about it because it's the future. It's really like learning computers in the past. If you don't learn computer nowadays, you are not able to read and write anything. Artificial intelligence is just a way to make the machine mimic a human thinking, give ideas that is important for human thinking. It is the future in healthcare. The past was minimal. It's simply taking input in the form of multiple data and giving an output that we need in healthcare through a number of algorithms. Many of it are hidden. The more those algorithms in number, the more complex is the formula, which means better data and better outcome. But in effect, we need more data to have a better outcome. The number of articles written about artificial intelligence in 2013 in medicine were just less than 50. In 2016, they are almost 250, and 2023, we are talking about hundreds and hundreds of articles written in different fields of artificial intelligence. They are using different algorithms. You don't need to go through that, but generally, machine learning and artificial intelligence are black boxes written by non-physicians most of the time to produce medical data, and this is where the danger is, which means you don't know how it is produced, is a black box. In the past, genomes were difficult to discern. Nowadays, using artificial intelligence, you can get and read and reach conclusions in genetics much better than any time in the past. And in effect, actually, the complexity is made easier by using the machine. Artificial intelligence in healthcare is something that produces data to the individuals through different pathways that are impenetrable, which means it's a black box. So either you trust it or don't trust it, and that's the problem. Artificial intelligence in many areas, in non-medical areas, has superseded human beings. What about in medicine? Yes, in imaging, dermatology, diagnostic, diseases, pathology, ophthalmology, drug discovery, precision medicine, prognostication, all of these are actually in the way to be taken over by artificial intelligence. There are devices that are doing that in seconds, give you answer that takes sometimes weeks in the past to do. A study, for example, done in Ontario using artificial intelligence managed to predict infection in neonates 48 hours before they occur, based on different criteria. This can never happen using clinical indication and the clinical medicine alone. Wearable devices, the Apple Watches, the Samsung Watches, and others, triaging a patient to different areas, monitoring patients at homes, are all artificial intelligence. It is a sophisticated way to assist clinical practice. It produces and improves accuracy based on feedback, and it assists physicians by providing up-to-date medical information about patients in general. The areas that were affected mostly in the studies and the development, as you can see in different years, mostly diagnostic imaging, after that genetics and electrodiagnosis. This is in the past in 2016. Nowadays, every other area is affected, especially genetics. I'm going to go through some of them: clinical, disease prediction, translational, public health, epidemic infection. For example, COVID was actually solved using artificial intelligence. Most of the progress, though, nowadays in diagnostic imaging in this blue pie and others we talked about. And there are a lot more related to radiologists using and adopting artificial intelligence, RNA expression, electrodiagnostic ideas are all those part of artificial intelligence. Diagnosis of cancer, prediction of breast cancer, diagnosis of Parkinson's disease, imaging analysis, chest X-ray reports, all done through artificial intelligence. You don't need a human being other than to put the data, the machine will start working for you after that. Diagnosis of PAD, 90% accuracy. Cerebral ischemia, 95-86% accuracy. Early stroke prediction and diagnosis much better with machine. Performance of patients with a stroke much better with the machine. TBA dosage based on the patient characteristic also is done better with the machine. Predicting the 3-month treatment outcome is much better with the machine. Prediction, ulcer healing, stroke treatment, endovascular intervention, type of vascular intervention, open versus endo, and education is going to be using artificial intelligence. Medical office in the future will not be like that. It will be like those people sitting somewhere and talking to people. There will be no delay. They will not call sick, and you'll not have to worry about replacing them. Education and medicine is here to stay, and artificial intelligence is here to stay with that part. I thank you very much for allowing me to have this very short and fast presentation about artificial intelligence in medicine, and I'm happy to answer any question.
Thanks, Dr. Munir. Now we are moving to the second presentation. Dr. Konrad Goraz, Germany. He is a pediatric surgeon. We're talking us about the visualization in surgery.
Good morning and good day to Hurhada. I'm very proud for that invitation. Thank you very much. I'm Professor Kaj. I'm working in the Ludwig Maximilian University in Munich, in Germany. I'm general surgeon, visceral surgeon, robotic surgeon, and that's why we will talk today about computer vision and the robotic surgery. Let us start. I will share my screen. So now you can see everything. I hope I will make it bigger, the presentation, like this. So what is the computer-guided surgery as a coming reality in the robot-assisted surgery? What is happening with us? Of course, I have no disclosures and no company is paying me for the lectures. So probably it is mostly this what I'm thinking about the robotic surgery and computer-guided surgery. What is happening? What happened with the in the operating theater with the robotic surgery? We introduced the computer between the patient and the surgeon, and this is the great achievement because we get the tool which allow us to get completely new dimension of surgeries which we will perform in the future. This is some divisions what we can add because of computer and in the visualization during the surgery. We can use biophotonics. We will talk about it a little bit. Augmented reality, which we heard about, but mostly we still don't use it in ORs. The computer vision, this is the computer programs which we are allowing us to understand much more the situation during the operations. We will have sorry, completely different support systems which will allow us to work on workflow during the operation, and you will see that the glasses, the virtual glasses, or augmented reality glasses, or mixed reality glasses will be introduced into the OR in a very wide manner. You know probably a little bit some visualizations and video technology using biophotonics during the general surgery. We have the normal image, we can have a fluorescence, we have the selective illuminations. We could have also, can we see also the oxygen saturation today or blood perfusion on time? What is absolutely very interesting. Only few technologies today are available with the robotic surgery. It is only the selective illumination and near infrared fluorescence. and of course the normal color image. What is the fluorescence? The most popular one is the ICG fluorescence, where we give the indecent green intravenously or in organ, which we want to present. We are getting it as a green color additional on our video picture from the operations. What is good for? We can have, of course, the blood perfusion, which we are seeing on time intraoperatively. We can use it for lymph node mapping. We can use it by differentiation of embryonic layers. We can use it by specific ICG inflorescence this is a combination between antibody and ICG. And of course, by the liver surgery, by BILDAX, or to visualize the ureters and the liver functions. This is what we did. This is the differentiation of the embryonic layers with ICG. We put just ICG as a perfusion into the lower mesentery artery, and then we could achieve to make the colored all the space meant with rectum. As you see, you can recognize the planes and layers very easily, and it was a great achievement. This is the porcine model. We tried to do it by patients, but it was much more difficult because of the difficult preparation during the operations. This is another example for the ICG, the oncologic resection of stomach, which you see the lymph nodes mapping. We introduced the ICG into the tumor, and then 24 hours later, we received such a beautiful picture with the station of the lymph nodes, which are here, green on the picture. Yes, as you see, that those green pictures are not from the camera, from the robots, from robotics, and computer-guided surgery will be the driving force towards autonomic robotic operations in the future. Thank you very much. Have a great Congress. I wish you all the best, and very, very nice regards from Germany. I'm with you today. Take care. All the best. Bye-bye.
Thank you, Dr. Konrad, for your informative lecture. And now move to next speaker, Dr. Muhammad Omar Al-Farouk, our active and elegant lecturer. Please let us enjoy your lecture.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation, Professor Nasser Said. I would like to summarize my lecture in just one sentence. And my sentence will be every vascular, yes, it will be 1 minute. Yeah, I can finish after that. Every vascular surgeon can start his artificial intelligence programming by today. You don't need to buy a computer. You don't need to have a high terabyte CPU. You don't have 20 gigabytes. All this is supplied free of charge by Google, and it's free access by today. So let me summarize over the next 8 minutes the AI and machine learning to vascular surgeon. By the way, I used to speak to Konrad. He is interested in artificial intelligence. He thinks that by year 249, the machine learning will solve the problem of death. With a huge mega data, he will know exactly what to do, when to prevent this. But luckily, me and him will not live to that day. But that day is predicted by artificial intelligence. He can even solve death problem. For a religion point of view, I don't believe this is happening, but at least this is an information. So AI and machine learning for vascular surgeon. Now it's become mandatory in most universities in the United States, first year, to study AI. I am involved in one of these universities, and by graduation from first to second year, you have been asked to get an AI project done. So I made a free course. If you scan this QR code, it will get you over the free course right away to all vascular surgeons. Just by having this QR code, you can log in, see the information, and you will get invitation for a free course about AI. I will go very quickly. This is my intention. I want that everyone to learn artificial intelligence. The computer language is called Python. Python is very near to basic English, and there is a book which learns Python in 1 day. So you can learn the computer language in 1 day. You do not need to buy a supercomputer. You go to Google Colab, which will give you the computer, the CPU, and all the Python programming. You don't need to install anything. You can actually do programming from your Android phone. Why it is important? Because I think it will revolutionize the way you think about diseases. So this is the intention of the course. I will go very quickly. The course is for 1 year. Usually you spend 2 hours per week, and by the end, you will get certification that you are AI specialist. Now we all are using ChatGPT, which really fantastic. You can give a diagnosis to ChatGPT. It will give you the information, the background, what you do next to the patient. It can give you a summary of the progression of the disease. It's really amazing. And to know that it has been owned by Elon Musk, and just saving the data in Amazon Azure, you pay $3 million per day, just keeping this data. This ChatGPT is more intelligent than us. And this is the beginning, because the ChatGPT 4 is 10 times more powerful than ChatGPT 3. I'm not sure if you have used it for vascular indication, but it's amazing. It's really amazing. And this is due to artificial intelligence. So I will go very quickly. Just one slide. I will spend some more time on it. You don't need to have a previous computer language. I used to be computer programming about 30 years ago with something called machine code. But now it is bloody easy. You don't need to run it for a long time. You don't need to buy a computer. You don't need to buy anything. You can actually do it by tonight. So you don't need a computer programming to do artificial intelligence. And I think these are the people who need to have it, both nurses, physician, medical history. And to learn an AI, it's very easy, software. You don't need skills about it. You don't need even have a computer background. It is as simple as that. And this is the benefit of the course. Of course, now, you know, machine learning is now diagnosing a chest X-ray in United Arab Emirates. It's not done by intervention radiologists. It's all done by AI because it's cheaper, it's 24/7, it is more accurate than a physician. It will come a stage that we'll have an AI in vascular medicine, angiogram will be more accurate than us. This is an important point to jump in. 2 hours per week, it's an easy course. I will go very quickly because this is an instruction of Professor Nasser al-Saeed for you to have a nice supper. I've been asked to give a presentation about AI to American University in USA for first year medical student. I will be surprised when they graduated what the level they will reach. And you don't need to, this is the important page that I want to spend time on. Now this page is Google Colab. Anyone who have Gmail, if there was a pointer, it would be fantastic. So that's a pointer. So anyone with a Gmail will go for this application, Colab. Colab is an application that free of charge. It's a beautiful idea by Google. It said, well, you want to do AI programming? Okay, I will give you a computer. When you get a cancer patient and you put all the data in and you get a program, it can diagnose benign cancer. Can you believe how many lines I've done it? In 6 lines. Just 6 lines I can diagnose benign from malignant tumor. It is as easy as that. And this is the computer supplied. This is the RAM. It will give you a hard disk which around 20 gigabytes of hard disk, and the RAM is about 80 gigabytes of RAM, random access memory. This is called supercomputer. In the old days, I used to do machine code, wait for 3 weeks to get an answer. This is maximum now, I wait for 10 minutes, maximum. I give them data, for example, a very famous program where cancer, they collected information about 100,000 cancer patients. It's cancer.cvi. I imported the data and then manipulated with using computer language called Python. And inside Python, it's what called library. So there is library to predict if are you accurate or not accurate. How you can assess the result. What is the best? It's a beauty. That is why the answer to my question of my dear colleague Assam Osman, how accurate are we? Well, in the chest CT scan, they are bloody accurate. They are more accurate than a consultant radiologist. So if you go to Google Lab, these are the section, which is totally free. You will have an account, and you will have a computer with RAM, and you can run the code. This is the codings that I have done just as a page. And you can run the code, and if you have an error, in the old days, we used to have a computer called the decompiler. Decompiler is a program that tells you when you are going wrong. Sorry. So now you don't need a decompiler. It will tell you if you have wrong coding and what is wrong in your code, and you can correct it. So believe me, we can do artificial intelligence. It will affect our practice. It is as easy as speaking. It's not more difficult than that. I have a program for diagnosing cancer. I'm eager to get a program that will diagnose venous ulcer right away, but I need images because machine learning eats on data. If you don't get enough data, and data is a big problem because of the security reason and patient conflict of interest. So my message, as simple as that. You can do artificial intelligence as you speak, and you can do it by today, and you don't need to buy any new tools. And thank you very much.
You are the moderator, so thank you. You're still moderator.
So because of time, I think I will give the announcement. Professor Nasser Said, if you want to have discussion, just give me the order.
Yes, you can start the discussion first, and any question?
Thank you for your informative lecture. My question is how we can use artificial intelligence in vascular surgery, just to take opinions and to or to intervene.
Excellent question. I didn't want to go into detail with artificial intelligence, but to do an artificial intelligence program, there are 17 steps you need to go. Diagnose the problem, get the data, perform a module, and this module you test and manipulate, and you get your answer. And after getting your answer, you start to improve your module. So these are the steps. So let us say, for example, I want the machine learning to diagnose ulcer, cause, etiology, is it arterial or venous or combined or skin disease or whatever. You need to get a data, huge amount of data, and you get a diagnosis, and you make the machine to learn which data will give you this diagnosis. The more data you have, the better your accuracy. And then the machine learns from itself with the data. And these are the steps. What are the idea in my mind that AI can do to us? Well, it can diagnose a presentation to you, give you diagnosis right away. If you have patient with venous ulcer, with anemia, bleeding, and for example, and acute pancreatitis, what is the diagnosis? It will give you exactly within seconds. It search all the medicine and give you the final diagnosis within a second. This is a beauty. Secondly, you can do your own program to diagnose venous ulcer, diagnose venogram, diagnose angiogram with certain accuracy more than the human eye. It has been done. Now, diagnosis of cancer breast is done by AI. it is not done by radiologists. And can you believe it is more accurate than the expert radiologist? So that's why it's gone. Yes, my dear Dr. Assam, fire your question.
Your excitement is palpable. It's contagious. But I don't know what I'm getting excited about. I'm excited, but I don't know what I'm getting excited about. Okay, let me give you a scenario. You say it's simple. Yes. Let's put it into play. So, Assam Osman is 58-year-old hypertensive smoking male of Sudanese origin. Okay?
Yeah.
Has a 5.8 centimeter infrarenal aortic aneurysm.
Yeah.
Okay? Is going to see Dr. Nasser for treatment, who is a consultant vascular surgeon of XX repute.
Yeah.
Can AI, if I put all this information in, predict accurately what my perioperative risk will be if I have open aneurysm repair or if I have EVAR?
Yes, absolutely right. It's been done by Siemens, and now they have already the software to be added to Siemens Zigo. They have put their, I think they have something like 80,000 angiogram with aneurysm intervention, and they put the complication rate. So the machine, when you feed him with this patient, DICOM loop, who will tell you he have a high risk of endoleak type 2A that is suitable to embolization by transvenous access. It will be as accurate as that. And there is a group now on Telegram, which is dedicated artificial intelligence in aortic disease, mainly American University. And they have a program to detect rupture. And I told you the accuracy now is 90%. So when you put the DICOM loop to AI, it will tell you, well, from the data I know that we human could never know, because he have seen all the rupture, you know exactly what.
It's part of the answer. Maybe we can take this conversation offline later on. Thank you.
Okay.
If you have any program to measure the surface tension of the aortic, this is to predict which will going to rupture, which will still have some times to.
Absolutely.
This will help us, and I'm dead sure will save a lot of money.
Absolutely.
Because you can make all your cases an elective basis rather than.
And he will tell you as well, do the operation with Professor Nasser Saeed. He will direct you to which surgeon to do it in which hospital.
Doesn't
and private and governmental.
Okay, thank you very much. Any more
Rashad.
questions? Yeah, okay.
So, Dr. Elena Goranova have in-depth knowledge about this subject of artificial intelligence. This is the topic of her PhD, so I'll leave it to her, but maybe she'll speak in French and I'll do the translation.
J'ai fait un travail plus de 3 années avec une prédiction de la rupture, du risque de rupture des anévrismes.
So she did a study about ruptured aneurysms.
More than 3 years. And I know today that, I know today that artificial intelligence is a tool to the experienced doctor, to the experienced surgeon. Yes, because today, in this moment, we esteem that dangerous aneurysm is more than 5 centimeters in diameter. But we can see some aneurysm who has 3 centimeters in diameter and they can rupture. So this analysis of artificial intelligence I used can predict is this aneurysm of 3 centimeter a risk of rupture or no, and can predict is another aneurysm of 6 centimeter or 7 can be ruptured or no. Because we know that there is many aneurysm more than 6 centimeter larger that they never rupture. Yes. Thank you.
So if I add a little bit more, if you give all the data regarding aortic aneurysm regarding the, the age and the gender and the smoking status and hypertension and the configuration of the aneurysm and thrombosis. If we give all this data, the artificial intelligence can answer the question, what's the risk of rupture of the aneurysm, taking in consideration not only the size, but other factors.
Excellent, and I can ask her to join our program to teach all vascular surgeons in Egypt artificial intelligence. You are very much welcome, and to explain the steps of the AI.
No, so you can explain for us, do you have a special program for learning how is it, for example, one like me, I even can't use the computer, so how I can start to be a breakthrough this artificial intelligence program to start with?
Yes,
you get my point?
Our university hospital for a period of 3 years, this software from...
Do you speak German, Dutch?
No, I speak French.
Because I can't understand French, but I can understand Dutch. Even both.
No, your English is excellent. Your English is excellent.
Yes.
Thank you. So we buy this software from a guy from Finland for 3 years. His name is Gasser.
Well, we
Gasser,
can...
No, I mean you have
He's mathematician
a
and
program
engineer.
for your doctor teaching them how can you get breakthroughs this field in your centers or...
He's asking, do you have a program to teach doctors how to use artificial intelligence?
No, for this moment I don't have.
No. So you are
we can
exactly like
elaborate.
us, in the same level.
We can elaborate.
Thank you.
The last question, please, to Dr. Okay, Dr. Omar, despite we use the artificial intelligence and the complication that might happen, who will be accused by the end and who will go to the court? At regard, if we use the artificial intelligence and there is complication that might happen during the treatment, whom will be accused?
Yes, you probably didn't go to ChatGPT, but if you go to ChatGPT, on the first page it will tell you this information is being gathered by data until 30 December 2021. Secondly, this data is advisable for your practice. So there is no medical legal issue to use an AI to help your patient. There isn't a problem. And believe me, because I have done some AI program, it is, I wouldn't say never wrong, but if it was wrong, it will be on the basic of neural network designed in it, not to do anything else. And now we as human, we are facing something more intelligent than us, which is ChatGPT 3. Have a conversation with it tonight. It's amazing. And this is pure AI, actually not a sophisticated AI program, but the amount of data that feeds on it is unbelievable. And I've told you, they pay $3 million US just keeping this data alive by Amazon Azure. So I wouldn't say they are never wrong, but I would say 99.999, about 10 times, they are right. Yes, exactly.
Thank you, Dr. Mohammed. Thank you, Chairman. Thank you all. So I just would like to make sure all of you will start tomorrow at 8 o'clock sharp. Please, before you leave, we can just have a picture together, like each time. So let us start.